She said that. One's charting and the other two I forget. Like these. One's physical, one's. Do you remember the 3 skills on the test? One can be charting and the other two are.
One ADL skill.
Oh, okay.
One mobility skill, and one documentation.
Documentation, okay.
So in your skills book, on page 20 something, right there, that page right there, that page, gives you all of the testing here.
So 3 of these.
There, what?
We did that in the class, so if another stranger there with you can actually brush your teeth.
Yep, you will be performing these skills on live humans. Most of them.
Yeah.
There are some we're going to do on mannequins,
Right. But the teeth brushing was actually on the person.
on real people.
We would have to. It's like, oh, please don't nobody get that for me. I'm brushing my teeth.
Yeah, nobody likes to be a patient for mouth care,
Right.
foot care, or feeding, but it is necessary.
Yeah, I guess you got to be a good patient for them. Yeah.
Well, there's something too as well. Remember that we learned it's all about the patient,
Right.
right? We've learned that. You've heard me say that over and over and over and over again. It's always about the patient. Well, if we don't play that role, it's difficult for us to understand what it's like from the patient's point of view so that we can make sure we're focusing on the patient. So being a patient for the test actually serves a very important purpose. And that's why you should be practicing on each other in class as well, because it really is difficult to understand what life is like for the patient unless you've been in the patient's shoes. Does that make sense? So while we're on that subject, before we get started, I want to, this is something I wanted to talk to you guys about today. Okay, we have sound. All right. Hi, YouTube world. So I told you I'm plugged into a lot of these CNA and nursing groups online, and I, read all these comments and stuff. And one of the posts this weekend, of course, was about Halloween and how many of you guys get to wear costumes. And a lot of people were grumbling in the comments that we don't get to wear costumes. It's so unfair. Just a lot of grumbling going on. Good morning. Good morning. But I want to stop and think about that for a second, not from our point of view, good morning, but from the patient point of view, right? So whether or not you get to, whether or not you get to wear costumes for Halloween, is really going to depend on the setting that you're in. Good morning. So let's think about this kind of setting by setting for a second, okay? Let's talk about the hospital first. So if you're a CNA in a hospital, you might feel it's unfair that you don't get to wear a costume on Halloween. And that is kind of unfair. I mean, other industries get to wear costumes, but let's think about this from the patient point of view for just a second, okay? So when we have a patient who's in a hospital, they are having the worst day of their life. They're not home. They're not able to pass out candy. They're not able to dress up. they're actually kind of focused on themselves at the moment. They have something going on that is serious enough to land them in the hospital. So we have to understand their mindset. Okay, I'm not even talking about ICU. I'm just talking about the regular hospital. Okay, the regular med surge areas. So why would they object to someone coming in a uniform or a costume? Well, there's only 2 types of costumes for Halloween. I don't know if you guys realize this. There's 2 main types of costumes for Halloween. One of them is creepy, spooky, scary, macabre, whatever your term is, right? The other is cute and flirty and silly and fun, right? So those really are the 2 types of costumes that you see on Halloween. Either scary or silly. We'll kind of group them together. Okay, so if you are a patient in a hospital, is scary appropriate? No, they're already terrified out of their minds. We don't need a costume to help push that along. So scary, definitely not appropriate. But what about silly? Well, do you really think this is the time and the place when our patients are hyper focused on their own issues to have silly in place? Probably not. They're not going to appreciate it. At that point, the costume isn't for your patients. Who's it for? You. Yeah, and in healthcare, it should be all about the patient, not us. Make sense? Okay. Now, in the ICU, this becomes, or the ER, this becomes way more important. Imagine grandpa getting wheeled into the emergency department, having a heart attack, needing CPR, and this cute little pumpkin is doing CPR. I mean, you want to talk about something that can scar a family for life? That would do it. First of all, they don't look professional enough to be able to perform the skill, but also you really should not have silly in this type of situation. Does that make sense? Okay. So when you're talking about critical areas like the ER and the ICU, costumes are not appropriate at all. Now, let's go on to long-term care, nursing homes, assisted living facilities, home care. Yeah, costumes are probably appropriate there, but probably not the scary ones. Imagine somebody coming into your room that you don't know, dressed in a scary or bloody or whatever costume, right? That could be very, very upsetting. Let's think about mental health. Now, in mental health, CNAs work in mental health. In mental health, we need consistency. That is the key to helping people overcome mental health challenges, is consistency. Costumes, there's no consistency there. That can really set somebody that's having mental health challenges back a little bit, right? Pediatrics. Well, yeah, pediatrics is probably okay for costumes because we're dealing with children, but they need to be silly, not scary. We never want to make pediatric patients afraid of healthcare. Does that make sense? So the answer to this dilemma, is it okay for CNAs or medical people to wear costumes in a healthcare setting? The answer pretty much is no, along most lines, with a few exceptions. Does that make sense? Okay. So staff parties, absolutely dress up. Your family parties, dress up. Halloween night when you're not working, dress up. But when it comes to working in a clinical facility, we really do have to remember that it's all about the patient, not about us. And the decisions that are made with that in mind. Does that make sense? Does that give you a little bit different way of thinking about it? Yeah, I could have put a witch's hat on today and, kind of played up Halloween because it's tomorrow. But that's going to affect how you see my instruction. So because I want to keep this as professional as possible, I'm not dressed up. Now, tomorrow night when I'm handing out candy, I will be. We have to know our boundaries. Make sense? Good? All right, let's go ahead and get your scores for chapters 2 and 3. I know these were super long chapters. Super long chapters. So it's going to be on page 182 and 183 of your white book. Everybody ready? Page 182 and 183. Stacy.
I got one wrong.
On 2?
For both.
Okay, for both of them. Got it. Cassandra? Natasha?
I didn't finish it.
Okay, it's fine. Do you have chapter 1 for me by any chance?
I left it at home in the yellow book, but I can bring it on Wednesday.
Sure. Yeah, I'll just keep asking you until you give it to me. No worries. Jenna? Dwight? On chapter 2?
Yeah.
Okay. And what about chapter 3? Okay, it's fine. Do you have 1 for me? Chapter 1?
Only one wrong.
Very good. Okay. Dalton? Regina?
Chapter 1, I have 2 wrong.
Okay.
The 2, I have just 1 wrong.
Okay.
3, I have 4.
Okay. Thank you. Cheryl?
She doesn't have the book yet.
Okay. Okay. So, okay. So you missed the whole first week of class?
We were doing it on the YouTube.
Okay. So you were following on YouTube? Good. Okay. All right. Brittany?
I got 100 on chapter 2 and I missed 1 on chapter
Thank you. Nicholas?
I got 100 on chapter 1, and 85 on chapter 2, and 95 on chapter 3.
Thank you. Angela?
I missed 1 on chapter 2 and 2 on chapter 3.
Okay. Thank you. Felicia?
100 on chapter 1, 95 on chapter 2, and 100 on chapter 3.
Thank you. Marie?
I have 100 on chapter 1, 200 on 100 on chapter 2, and I missed 2 on chapter 2.
Okay. Thank you. Catherine?
95 on 2 and 100 on 3.
Thank you. Alina?
On 2 I missed 1 and on 3 I missed 2.
Okay. And Mariana?
Um,
You need the book. Okay. All right. Any questions on the ones that you missed? Any questions? Do you know why you missed it? Do you know what the right answer was and why? Everybody good there? Is there anything you want me to discuss with you? Okay. And I'm going to have to print you out another service. Okay. Is everybody getting our wrap-up emails? Everybody getting the wrap-up emails? If you're not getting the wrap-up emails, please let me know, and we can check your email address because that's going to have a lot of important information in it. And there will be things in the wrap-up emails that I'm not talking about in class, links to items and stuff. All right, so we did that already. All right, so let's review. There was a whole weekend. Let's make sure you didn't forget what we learned. Okay. All right, so how do we know what to do with each patient? The care plan, okay. And we're going to follow the care plan, the whole care plan, and
Nothing but the care plan.
what does that mean? What does it mean if we're following the care plan, the whole care plan, and nothing but the care plan? What does that mean? Anybody know?
That we shouldn't perform what is not there.
Right. So we're not going to add to the care plan. We're not going to take away from the care plan. We're not going to change the care plan in any way. We're going to follow it exactly as it's written. And if we can't, what do? Report it to the nurse. So while we're following the tasks that the care plan lays out for us, what should we be doing with the patient? Observing. That's right. So we're looking for any changes or abnormalities or pain or anything that we see, hear, smell, or feel that just doesn't seem right. Correct? Who do we report those to? The nurse. Easy peasy, right? So we know skill rules. Good job. All right. So remember that the care plan has to be followed exactly for every skill on every patient. There's no deviation here. There is no wiggle room ever. When you start to deviate, you have now put yourself in a liability position. The nurse is not accepting liability for you if you are off the care plan. So it's really, really important that we understand that to limit our liability. Okay. So every skill starts with an opening. What does every opening start with? A knock. Right, because patients have the right to be in a safe environment. And that's what the knock does, is it helps reinforce that safety because everybody that comes in is being announced first. Good? Good. Okay, once we've knocked, who are we going to greet? The patient, because it's always about the patient. So we're going to greet them. And then what do we have to say? Their name. Yeah, we have to address them by name. Now, this is because patients can self-identify. And if you call them the wrong name, they're going to say, hey, that's not me, because they don't want whatever you've got in store for whoever else you just talked about. So they will tell you if it's the wrong person. Now, if we have a patient who, for some reason, can't self-identify, that would be found out during the assessment. Okay, we would discover that during the nurse would discover that during the assessment, and then she'd have something on the care plan to tell you how to identify that patient. Okay, so we already have a process in place for this. For the test, we're simply going to address our patient by name. Once we've done that, what do they need to know about us?
Name and title.
Yeah, not just name, it's name and title. That's right. So I'm Patty, your CNA today. Way different from, hey, I'm Patty. Okay, there's lots of different people that work in a clinical facility. They have no idea who you are and what role you're going to play. You could be from dietary. You could be from social services. You could be from a volunteer. I mean, they have no idea who you are unless you tell them both your name and your title. So don't forget that title. It's actually a graded checkpoint. Okay. Now, once they know who we are and what we are, oops, hold on. Oh, that one's okay. That's fine. Oops. Okay, then we want to make sure that we're describing the skill that we're going to be doing. So the skill is, you can put it in your words, you can read it off the care plan, but the patient has to kind of understand what you're there to do. So I'm here to take your vital signs. I'm here to count your pulse. I'm here to do foot care. I'm here to feed you a snack. What are you doing? You've got to describe the skill, because the patient has the right to refuse, but they can only really refuse if they know what you're about to do. So we're going to tell them what we're doing, and then we are going to get permission. So we're going to ask, is that okay? Permission is important. Do we ever have the right to put our hands on another human without their permission? Anybody remember what that's called when you do that? Battery. And you can be charged with battery in a healthcare setting. Just because they're there doesn't mean that you have the right to touch them. Okay, good. Healthcare workers get that mixed up all the time. They think that just because a patient is in a clinical facility, that we have the right to do whatever we want to with them. And that is not true. patients don't give up their rights when they walk in the door. And we see this a lot because a lot of times patients won't want things that are good for them. They will refuse showers. And you're like, dude, you need a shower. But they have the right to refuse. We can't grab them and force them into the shower. That's not our job. Good? Make sense? Okay. All right. So we're going to describe the skill and get consent. And then after we get consent, we're going to close the curtain. That's right. And we're going to do this for every skill except for one. And we're going to get to that a little bit later in the program, but we are going to close the skill or the curtain for every skill. Now this, for some of you, is going to be a little like, well, why do we have to close the curtain for pulse? I mean, that's not really, doesn't really require privacy. Well, our rule is that we're going to close the curtain for all skills except for one, because it's not up to us to decide when we should be providing privacy. Privacy should be provided. Okay? Does that make sense? Not up to our discretion. All right. So once we've touched that curtain, is that curtain clean? No. Who touches it? Everyone. Yeah, it's full of cooties. So what do you want to do now that you've touched that cootie covered curtain?
Wash your hands.
Wash your hands, correct. And after you've washed your hands, you can then get your supplies. Yep, get your supplies, whatever you're going to need to perform that skill. So remember, you want to be touched with clean hands. So does your patient. So we want to make sure that we wash our hands before we touch the patient. That is the most critical checkpoint. Jorge passed. Congratulations to you. Great job. We are super, super proud of you. And thank you for letting us be part of your journey. All right. So every skill has to start with the opening, and the order matters in the opening. So your opening should sound like this. Hi, Miss Jones. How are you this morning? My name is Patty. I'm your CNA today, and I am here to whatever. Is that okay? Close the curtain, wash my hands, get my supplies. Every skill starts with the opening. It always goes the same way. Learn it. We're going to be doing it over and over and over and over. Never varies. All right. Now, some skills we're going to need gloves. Can we wear gloves for all skills? Why? Why can't we wear gloves for all skills?
There's no need.
Okay, there's no need. Sure. You stop paying attention to what you're touching with those gloves when you wear them without thinking about it. And who could that put in jeopardy? Yeah. So we're not going to wear gloves for everything. We're going to wear gloves when we need it. So how do we know when we need it? Well, there's 3 rules that we're going to look at. So if I'm going to touch body fluids, if I'm going to touch personal skin or non-intact skin. Good? So if the answer to any of those is yes, I need gloves. If the answer to all of those is no, I don't need gloves. But I am going to wash my hands before I touch the patient because that's part of the opening. And I am going to wash my hands after I touch the patient because that's part of the closing. Good. You don't have to have gloves for every skill. And remember, gloves are not the magic suit of armor that you think they are. Remember that things can get through gloves. So even if you wear gloves, what do you need to do when you take them off? Wash your hands. Very good. Remember, they just add an extra layer of protection. But if you are going to wear those gloves, what is the first thing that those gloves should touch? The patient, not the supplies, not the bed, not the curtain, not anything else. The first thing your gloves should touch is the patient. That keeps your gloves clean for that patient. All right, so we really do want to pay attention to what we're touching in the environment once our gloves are soiled, though. So once we've touched that patient, don't touch a lot of stuff and spread those pathogens throughout your environment. So be careful about what you're touching after you've worn your, or when you're done with your patient care and you're wearing gloves. Then we have to remove those gloves correctly to prevent cross-contamination. Do you guys remember how to do that? We're going to pinch up, not go under. We're going to pinch up, remove that glove, and then we'll go under on the second one. Skin can touch skin, glove can touch glove, but skin cannot touch glove. Good. Question? All right. Remember, gloves are not your magic suit of armor. You still have to wash your hands after. All right, so if we need some supplies, we have to have a clean place to put them. So we're going to use a barrier. A barrier provides a clean place to put your clean supplies. Clean supplies need to stay that way until they're used on the patient. So we only touch supplies with what kind of hands? Clean hands. Very good. Very good. What can't your supplies touch? Why? Yeah, it's not clean. Very good. And the order here matters. We're going to wash our hands, get our barrier, put it on the table, then get our supplies and put those on the table. Remember, this is a two-step process. Don't try to do it all in one go, because you'll end up having to press your supplies against your uniform without even thinking about it. And that's going to put our patient at risk. Okay. So a barrier is going to be used anytime we use supplies. So lots and lots and lots of skills are going to use a barrier. All right. Linen rolls. What can't touch your uniform? Supplies, linens. Yeah. Anything you're going to use on the patient. So you want to be really careful here. Remember, if a principle is repeated on, or if a step is repeated on two principles, it's doubly important. Okay. So not having supplies touch your uniform, we see that on barrier rules. We also see it on linen rules. So that means that it is a critical checkpoint. This is how patients get infections that they didn't come in with. Remember, they're not going patient to patient picking up new stuff. How do they get additional infections? Yeah, from us. And this is one of the big ways that happens, is healthcare workers aren't mindful and our uniforms are not clean. So we hold stuff up against the uniforms that we then use on the patient, usually around their doorways. And that's what spreads infections. You guys remember that portal in, portal out? You guys remember that? Okay. All right. So we're going to have clean hands to get those linens. And what don't we want to do when we're working with linens? Snap or shake them. We just want to unfold them and lay them over. Anything that we don't use, what do we do with it? Okay. Can we leave it in the room for later? No, because anything out of our sight cannot be considered clean. Do we put it back in clean supply? No, because anything that's been removed from clean supply is not considered clean. Good? Look how much you guys learned in the first week. Amazing. You're doing great. All right. And then let's move on to privacy blanket. Remember that your perception of temperature is different from your patient's. You're fully clothed, running around like crazy because there's way too much to do. Your patient is not fully clothed and laying still. What's temperature going to feel like to them? What's temperature going to feel like to you? You do not have the same perception of temperature. So if you've got a patient laying in bed, they're vulnerable just because they're laying down. They're not dressed for company. They're just in a thin hospital gown and they've got a sheet on them and not much else. Now take that sheet off. What do they feel like? Freezing and probably exposed. Yeah. Is that a good feeling for our patients? No, you're a stranger. They don't know you. They have no idea what your intentions are. And guys, let me tell you, assaults do happen. in healthcare settings. Just because you're wearing a badge does not mean that you are a safe individual. One of the worst cases of health professional assault on patients happened one county north of us in Citrus County. Yes.
Work there.
Yes.
What happened?
We had a male nurse who worked in the post-op unit, the recovery room after surgeries, and he was sexually assaulting patients, raping patients when they came out of surgery. And they weren't awake. They were still under anesthesia. They could not fight back. And when they came out of anesthesia and were transferred to the floor, a lot of them started having stress reaction, panic attacks, because even though they were unconscious, parts of their brain were still registering what was happening to them. And they did not understand why they were having these panic reactions. And they started to investigate it. And a coworker actually walked in on this man in the middle of an assault. And that's how they caught him. But he assaulted, that they know of, about 20 individuals. Just because we have somebody wearing a badge, guys, does not mean that you are a safe individual. One of the other really bad ones happened out, I believe it was Arizona, and it was much more recent. It was about 3 or 4 years ago. A comatose woman in her 20s, she was a drowning victim when she was a child. She wasn't conscious. She gave birth in a facility. Now, she was in no situation to consent to any sexual activity, which means automatically she was raped. They did DNA tests. You know who raped her and impregnated her? Her nurse, her male nurse. Do not think that just because somebody is wearing a badge in healthcare that they do not have bad intentions. And that is why we need to make sure that the patients feel somewhat secure. If you take that sheet completely off of that patient and all they're wearing is a gown, they are going to feel vulnerable. And people in healthcare do bad things to patients. And they know that. That is not contributing to the mental well-being of your patient. Your patient needs to be covered. And that's what the privacy blanket is all about. If we need to move the sheet to be able to work with our patient, we're going to cover them up with a privacy blanket so that they're covered and warm, and there's a layer of protection to protect them from us. Make sense? Okay. But we don't want to take the sheet off and then give them a blanket because that makes them exposed. So we're going to lay the blanket over the sheet and pull it down underneath so they're always covered. Okay. So we're going to use a privacy blanket anytime the patient is uncovered or undressed. Very good. Okay. So the blanket goes over the sheet gets pulled down underneath. And again, we don't want to snap or shake the blanket, just like linens, because we don't want to aerosolize all of those pathogens. And then we're going to remove it at the end of the skill after we remove our gloves, because we don't want to pull that sheet up with soiled gloves. Remember, that sheet's going to go right up next to their face. Their face has all kinds of doorways in, so you don't want to touch that sheet with soiled gloves. We'll remove our gloves first and then pull the sheet up. Good? Questions? Man, we've learned a lot. This is probably the most important principle. Comfort and dignity are the two most important patient care principles. Patients don't care how much you know until they know how much you care. Okay? So comfort and care are important. So basins, we're just going to clean the basin like you clean your sink out at home after you brush your teeth. We're going to rinse it out and get the big globs out. This isn't about sterilization. It's just about cleanliness. But if we need to disinfect because our care plan tells us to, or our policy and procedure tells us to, we have a process for that. So when we're going to clean any patient use items, we're going to dump it where it normally goes. Sink, toilet, where does it normally go? And then we're going to rinse our basin and dump the rinse water wherever we put the stuff. So if we're dealing with urine, we put the urine in the toilet, we rinse the basin and put the rinse water in the toilet. If we're dealing with mouth care, saliva, we're going to dump that in the sink, rinse the basin, and dump the rinse water in the sink. Good. Once we've rinsed it, then we're going to set it down. Because if we have to disinfect it, you can't hold it with dirty hands or dirty gloves while you're disinfecting it. So you got to set it down and spray it. Now we have a clean basin, a disinfected basin. You can't touch that with your soiled gloves. So we're going to use a paper towel to pick it up. Good. Then we'll use paper towel to dry the inside, use paper towel to dry the outside, and then we'll grab one to get the supplies and open the drawer. Remember, you don't want to touch that drawer front with soiled hands or soiled gloves. We want to try to keep those as clean as possible. Good. Remember, it's not about sterile. It's just about as clean as possible. These are still people. They still are in the room. They're still going to touch stuff. We're never going to get sterile. We're just trying to get it as clean as possible. All right, after we're all done with that, we'll throw all the paper towels away. And remember, all basins are cleaned the same way. It doesn't matter whether it's a wash basin, a bedpan, an emesis basin, a graduate container. It doesn't matter what it is. If it held liquid, we clean it the same way. And then finally, we have the closing. Now, the closing is complex. 9 steps. Lots to do here. Order doesn't matter, except for the last 2. Okay? Order doesn't matter. But we can think of this as the 8 C's of the closing. So we want to make sure the patient is in a clean environment. And my principle is always leave your patient looking better than you found them. Clean environment. So you want to make sure there's nothing on the overbed table, the sheets are arranged properly, nothing on the floor. They need to be in a clean environment. We want the bed to be in the lowest position, closest to the floor. Lowest position. We're actually going to be talking about that a little bit later. And we need to say the word comfortable. They need to hear that word comfortable. So are you comfortable? And part of comfort, not just physical, but we also have to think about emotional comfort. People have the need to be distracted, to be entertained. We don't like to be bored. We get destructive, like puppies. Anybody ever have a puppy? When a puppy is bored, they get destructive. Do you know people are the same way? When people are bored, they get destructive because that's a form of entertainment. Guaranteed to get some attention. Your patients that are bored, do you know how they're going to be destructive? They're going to use the call light, or they're going to pull out their tubes like their IVs or their catheters, or they may even throw things across the room. Yeah, we want to avoid that. So let's offer them some sort of emotional comfort. A magazine, TV, cell phone, crossword puzzle book. Give them something, because otherwise they're going to be on the call light or pulling out their tubes to get you to run in. It's all about entertainment. Okay, so are you comfortable? And we're going to offer that magazine. Head of the bed is all about comfort. So we're going to just ask, do you want the head of the bed adjusted? That we can ask that. If they request it, you definitely want to address it. And we're going to open the curtain. So the way I kind of remember this is clean and safe, comfort, curtain, call light. It covers all of that. Good. Once we've done all that, then you need to go, give them their call light. Then you need to go clean your hands. You got cooties all over you. We don't want to take those cooties to the next patient. So go clean those hands. Now, if we're going to document, if documentation is required, we'll document after we wash our hands. We'll document after we wash our hands. And then what do we have to do again? Wash our hands, because remember, our checkpoint is end skill with clean hands. So if we document, we have to wash our hands again. So any questions about this? Always leave your patient feeling safe and cared about. Those are two very important principles. Now, I know you're going to be nervous for the test. I get it. You're being tested. It's a scary thing. People are watching you perform. And that's probably the worst part of the skills test, is you're being watched and judged. And a lot of people get really, really stressed out about that. And when we were a testing center, people would be throwing up in the parking lot. They would get so stressed out about that. Okay, you're being watched. But what a lot of CNAs don't realize or don't really think about is that the test is just the first time you're being watched. Because every skill you do from here on out is going to be watched by somebody. And if you think that RNs that are testing you are tough, try the patient's family. You will be watched. You will be watched by the patient. You will be watched by the families. You will be watched by your coworkers. You will be watched by the nurses. This is just the first. It is not the last. So when you start to realize that, the test actually gets just a little bit easier. Okay? Good. And trust me, families, way more critical than the RNs will ever be. Ever. When my mother was in the hospital, she was in the ICU. She had an intestinal abscess. They had to take out part of her intestines. She had a drain put in. She was in critical condition. It was touch and go for a little while. I stayed at her bedside. You don't think I judged what was happening to my mother? No one was allowed to touch her until I had physically watched them wash their hands. I'm talking about CNAs, nurses, and doctors. Because I know that those people are going room to room. I know the pathogens that are in this setting. And I know that one additional pathogen would kill my mother. I love my mother. I want to keep her on the planet for a while. So I was vocal about it. Don't you think that other families feel the same about their family members? This is why we really want to make sure that we understand how to do these skills appropriately, because every patient that we care for is somebody else's loved one. They're not just a body in a bed. Good? Questions on this? All right, let's move on. Oh, hello from the Philippines, Erlina. Thank you for joining. And Sarah passed the CNA exam Saturday. Congratulations to you. Great job. Great job. All right, so go to page 116 in your skills book, and we are going to learn a new skill. So we have a new face with us today. I want to introduce you to Amy. Amy is our marketing manager for MediScrubs, the retail store. But I'm also having her sit in on a couple of classes so she can kind of see what we do, because she's out marketing for us. And it helps if she understands what we provide in the classroom so that she can pass it on to other people. So Amy will be joining us off and on throughout our program to kind of see how the program works so that she can explain it to others, especially facilities. So Amy, class, Amy.
Hi there.
All right. So page 116 is going to talk to us about hand and nail care. Now, there's quite a few principles involved in this. We can see that by our principle listing on the side here. So we're going to follow every skill starts with a opening. We're going to evaluate if we need gloves. We have supplies, so we need a barrier to put them on. We're going to use towels and washcloths, so we have linen rules we have to think about. We're going to be washing something, so we have to learn some washing rules, and that's what we're going to learn today. We already know basin cleaning. We have some skill-specific steps we have to talk about, and every skill ends with the closing. So when you look at this, even though there's a whole lot of steps here, right, a lot of banners here, the only one that we don't know anything about is washing rules. Okay? So even though it looks complex, you already know about 80% of that skill right now. Without even seeing the skill, without reading the care plan, without knowing anything more, you know about 80% of that skill. So let's learn the rest of it. We're going to learn washing rules. Good? Everybody good? Am I going too fast? All right. So washing rules are going to be featured in 5 skills. We're going to use washing rules if we're going to do in catheter care, foot care, hand nail care, partial bed bath, or peri care. You're going to see it quite a bit. All washing skills are done the same way. Doesn't matter whether we're washing a hand or a foot or a backside or anything else. All washing is done the same way. So let's learn those rules so that we can apply them. All your notes are on page 113. So in order to understand this, we have to think about how we bathe, okay? How we bathe. So when you get into the shower, you get wet, you put some soap on, you scrub all your areas, and then what do you do after you put soap on? You rinse. You don't just get out of the shower with soap on your skin. Why? Why wouldn't you get out of the shower? Why do you rinse?
Because it'll dry your skin out.
It does. It dries your skin out, absolutely. And it makes you itchy. Yeah, it's not good for the skin. You would never think of not rinsing. It's part of your routine, isn't it? It never, I'm throwing you here. Well, what do you mean, why do I rinse? I rinse because I was taught to rinse, right? You never really thought about it. But it actually dries out the skin. Now, one of the things that we need to understand is as we age, our skin goes through changes. One of the changes that skin goes through as we age is that we lose our oil production. So older individuals are already going to have drier skin. Now, if we forget to rinse and we leave soap on the skin that's already dry, it's going to dry it further and it probably is going to crack or split. And now we've got more skin openings. What do we know about skin openings? What do they allow in? Pathogens. Is that a really good idea in a pathogen-filled environment? No. So rinsing, super important. Super important. So whatever we wash, we rinse. Whatever we rinse, we dry. Right? This step sounds so simple. You do it for yourself every single day. You don't even think about it. But the problem is when you're doing this on another human, you will forget to rinse. You will. You'll put soap on the washcloth, you'll scrub a dub, and then you'll just go dry. And we have to understand that that is going to have a major impact on the patient's skin. It's not healthy. It's also extremely uncomfortable for the patient. So whatever we rinse, whatever we wash, we rinse. Whatever we rinse, we dry. Good? Okay. So we understand that principle. Now, when we're washing something, our patient is not at the sink or in a shower. We have to bring the water to them. So we're going to go to the sink, put some water in our basin, and we have one basin of water. If we add soap to this basin, we are now not able to rinse. You guys see that? Now we know how important rinsing is. So if we add soap to the basin, we are not able to rinse. Good? So some of you are going to say, well, just go get another basin. That solves the problem. You got one with soapy water, one with rinsing water, solves the problem. Do you guys remember last week we talked about the costs of healthcare? Everything we get for the patient gets charged to the patient. You guys remember that? Okay. So if we do that, if we go get a second basin, your patient is going to be charged for that. And we don't need it. That's an unnecessary expense. Does that make sense? Okay. So let me tell you something that I find really, really interesting. One of the fastest growing segments of nursing, so nurses who are looking for jobs outside of traditional bedside care, one of the fastest growing segments of nursing is bill review. When you go to the hospital, you get a bill and it gives you a total, but it doesn't break everything down. It just gives you a total. This is what you owe. Will that be cash or credit? Okay. Now, you can ask, it is your right to ask for an itemized bill. So you can see exactly what they charged to you to come up with that total. And when you do that, you can take that to a specialized nurse that has had training and is registered. And that specialized nurse will go through that bill line by line and say, this unnecessary, this unnecessary, this unnecessary, this unnecessary. And they will get your bill reduced. Awesome, right? Well, those things were still used on the patient. So if the bill gets reduced and the facility doesn't get reimbursed for that, who eats the cost? The facility. Who pays your paychecks? Yeah. If they're spending their money paying for things that aren't getting reimbursed, how much money do you think is going to be left for raises? Yeah, this is why your wages are low. Does that make sense? We got to be careful here. When we use unnecessary supplies, it's going to have an impact on your paycheck. Every time. That CEO isn't going to eat it. You think they're going to give up their multi-million-dollar bonuses? Really? They're going to pass that cost on to you. You're the one that got the basin out. You didn't need it. I'm not eating that cost. You're not getting a raise. You guys see how that works? So we don't want to use supplies unnecessarily. It's bad for the patients, but it's also bad for you. Good? So, in order to be able to wash and rinse, which we know is important, I'm not going to add soap to my basin. I am going to get water in the basin and not add soap. Basins are no soap zones. Good? Makes sense? So, how do we apply soap then? We're going to take our washcloths, put them in the water, get them wet, wring them out, just like you. You get into the shower, you get wet before you put soap on. Ring a bell? Right? How many of you guys stand in a dry shower, water not running, and put soap on? That's weird. That's weird. You get wet first, and then you apply soap. Same thing here. We're going to wet our washcloth first, and then apply soap to the washcloth. And then we'll wash whatever we need to wash. How do we know what to wash? Care plan. Absolutely. And then whatever we wash, and then whatever we rinse, we dry. Starting to see the process?
So what?
Sure.
Why the basis you cannot reuse it? You cannot sterilize and use it on other patients?
Not on other patients. This basin, let's say that you're in the hospital, okay? This basin is charged to you. Okay, we get it out of our clean supply area. It is charged to you. Now, that basin is going to be cleaned and put in your bedside drawer for tomorrow.
So when you leave the hospital, what you do with it?
Take it with
You
you.
usually take it with you.
Well, but if I don't want it,
Then they throw it away.
so there's not a place in the hospital where
No.
you can sterilize all this stuff and
No,
why not?
because of the pathogens.
Someday that may change though,
It probably will.
right?
Yeah, I kind of
Whoa.
see that changing probably in the next 50 years
I
just
hope
because of
so.
the amount of medical waste that there is. But right now, no.
Because the linens are sterilized when they.
They're just washed. Yeah, they're not sterilized. They're just
What
washed.
do you reuse it in another?
Right.
So this is what I don't understand. If you can reuse a bed sheet,
Well, we used to 1,000,000 years ago, which is really only like 30 years ago. We used to, everything that we used for patients was stainless steel.
Or enamel.
Or enamel bedpans. That was a big one. But yeah, we did reuse a lot of things, and then HIV happened, and that's really where the turning point came. Everything pre-HIV, so everything early 80s, was all reused. It was just cleaned and reused, patient to patient. But then HIV happened. And HIV was a major health crisis in the 80s. And we didn't know how it was spread. And to help prevent, while we were learning about the virus, because we had not seen anything like it. So while we were learning about it, we switched from multiple patient use items to single patient use items because patients were scared. They didn't want anything that was used by another person because we didn't know how HIV spread at the time.
so
Well, then we had single use items that got, either thrown away or taken home by the patient. And that is now the standard. So that's what patients expect. So it hasn't changed back. I think it probably will just because of medical waste eventually, but we're not at that place yet.
So do you know how many people take it home, like in percentage, 20%? Or
Oh no, most people do. They use them as cleaning buckets or throw up buckets, or I've got one under my sink at home.
You do home care and you have a patient at home that goes to the hospital often. You go in their garage, you'll see 6 or 7 of them.
Yeah.
Closets. They bring them home all the time.
Yeah. There's also the mindset I paid for it.
Yeah.
I mean that's a big mindset. I paid for it. It's mine. I'm taking it home. Yeah. Yeah. Go to any yard sale out there, especially if it's an older person's yard sale. You will find all kinds of single patient use items, and along with wheelchairs and walkers and bedside commodes and
Shampoos and
everything. Yeah.
They're yours once you.
I paid for it. All right. So, basins or no soap zones. So let me get through this. So whatever you wash, you rinse. Whatever you rinse, you dry. And since we have to rinse the soap off the skin, we can't add soap to the water in the basin. That keeps our water clean for rinsing. So if we're going to get water in this basin to make this whole thing happen, we have to think about when we're going to do that. So we're going to read the care plan because that's always step one on everything, right? We're going to read that care plan and know what we're going to do with the patient. And then we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? I'm here to do hand and nail care. Is that okay? Close curtain, wash hands. I now have clean hands. First thing I'm going to get is a barrier because I got supplies to get. We know we get the barrier first and put it on the table. Then I go get my supplies. I need 2 washcloths. Excuse me, 2 washcloths. I need a towel. I need a basin, soap, lotion. I need an orange stick and an emery board. Man, there's a lot of supplies here. You have to memorize them. No way around it. Memorize them. Make it make sense to you, though. So I go get all my supplies, I put them on my barrier, and now I have to get water in this basin. So I take the basin over to the sink. Is that faucet clean or dirty? Dirty. And my hands are clean. They've only touched clean supplies. So I've got clean hands and a dirty faucet. Can I touch that faucet with my hands? No. So I need to get a paper towel between my clean hands and the faucet to turn the water on. Do you guys understand why?
Yes.
Okay. So don't touch the faucet with your bare hands once your hands are clean. Now, some people go way off track here. And they think, okay, well, I can't touch faucet. It's dirty. I got that. Good. So I'm going to put on some gloves to touch that faucet. But what are those gloves going to end up touching?
Why? In the patient.
The supplies, the patient, and what's the dirtiest thing in the bathroom? The faucet. So if we put gloves on and touch that faucet, we are putting our patient at risk. You guys see that? We do not use gloves to turn the water on. We use a paper towel. Good. Actually, a video online that puts gloves on and touches the faucet. Be careful. You have to understand infection control here, guys. All right, remember your hands are clean and the faucet is dirty. So we're going to use a barrier to turn that water on. And then we want to feel the water with the inside of our wrist. The water should feel warm.
So the paper towel is really a barrier?
It is. It separates your clean hands from the dirty faucet.
But you said even the rubber gloves, it's not safe enough. How a paper towel would be?
Because you don't want to touch that faucet. Okay? Your hands are clean. Your clean hands can't touch that faucet.
I understand. I'm just questioning
Right.
how safe is the paper towel if it's supposed to be a very special patient that could not have germs at all. You know, is the paper towel is really a good barrier?
Yes. Yes. Pathogens cannot get through paper towels. Yeah. It is a barrier. Because remember we talked about gloves, right?
Mm-hmm.
Gloves have holes, but there's two things that affect that: time and stretch. Okay, you remember that?
Okay. Yeah.
Right.
I do.
Paper towels we're using for a very short time, seconds, and there's no stretch involved. Okay. We don't want to use gloves. We're not trying to protect ourselves from the germs on the faucet. That's not what we're doing here. That's not what the barrier is about. We're trying to protect our hands from getting pathogens that we take to the patient. Okay? So it's not about protecting ourselves. We're going to wash our hands again at the end of the skill. That's not an issue. That's not why we're doing this. We're protecting our hands so they don't take contamination to the patient. So a barrier is effective. A glove would also be effective, but if you put those gloves on and touch the faucet, then you take those pathogens to the patient.
Unless you take the gloves off. You put
Yeah.
new ones
Sure,
on, but that's
sure.
a waste of gloves.
Right. It's unnecessary because a paper towel covers that. But I want to get to the other part of your question. What if we have a patient who is immune compromised and can't have pathogens anywhere? Well, our care plan would tell us the process to use for that patient. The nurse would figure out the right way to go about doing it to keep that patient from being put at risk. So you would follow your care plan. Okay, good. Questions? Okay, so we want to feel that water with the inside of our wrist. It should feel warm, not hot, not cold, just warm. Now for the test, those sinks have hot water. Every testing facility has hot water in the sink. The evaluator is going to check that water temperature to make sure it is warm, not hot, not cold, just warm. So if the evaluator is going to check it, you've got to make sure that it really is warm. Okay. I had a student not too long ago that failed the test. She went to the sink. She turned on the cold water. The evaluator was watching. Turned on the cold water, never touched the warm. Felt the water, said it's warm. Put the basin under there, and she did not get a checkpoint for using warm water. The evaluators pay attention, people. There is nothing they're going to miss. If you're over there and you don't turn that hot water on, you cannot say the water is warm. This isn't pretend land. They are really going to check the water. It had really better be warm. Make sense? Good? Not pretend land. We are really going to wash somebody's hand with real water and real soap. And we're really going to do the steps for real. So everything that I'm telling you counts. It counts. So make sure that water is warm. But it's not just enough for us to check it. Now, the reason for that is because our patients have different skin than we do. And I'm going to explain that in just a second. But we're going to check the water temperature, and then we're going to ask our patient to check it as well. Okay? So let me explain to you how this works. As we age, every part of our body ages too, including our skin and the structures under the skin. When we're young, we got nice, big, healthy, plump layers. Big, thick layers of skin, big, thick layers of fat, big, thick layers of muscle. This is optimal. This is good. But as we age, you can see each one of those layers starts to shrink a little bit. When we get older, our layers are super, super thin. How many of you guys have ever seen an old person's arm? Really old person's arm. It looks like veins right under the skin. Now, mine don't look like that. Yours don't look like that. But this older person, veins under the skin. That tells you that between the time that they were young and the time that they got old, something happened to their skin. What happened was that layer of fat that protects those vessels in our extremities, it gets reabsorbed. So you end up with skin over muscle with the veins in between. Now that layer of fat actually does a couple of really, really important things. So we got to talk about that real quick. So that layer of fat is kind of like a wetsuit that you wear all the time. And it helps keep your body temperature inside stable, and it helps protect you from outside. So in order to understand this, we kind of have to dive in a little bit deeper, okay? Anybody know what normal body temperature is? Normal body temperature? Anybody know? Any ideas? Okay, it's 98.6 is our normal body temperature, but it's actually a range. Anywhere from 97.6 to 99.6 we consider normal. But let's simplify this. 98.6. Okay? Now, our bodies are so sensitive that if we go below 95, it's hypothermia. If we go below 92, you are dead. 92, guys. If this room were 92 degrees, what would you say it was? Hot, absolutely. And yet our bodies, if they go below 92, you are dead. Not maybe dead, you are dead. Everybody got that? So we have to stay in a very narrow range. Very narrow. Now, the problem with that is that room temperature always wins. Always. Always, 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 always. Room temperature always wins. Let me prove it to you. If you take a cherry pie and you put it in the oven and we bake it at 350, it gets, what does it get? Hot, right? Bake a cherry pie at 350, it's going to get hot. take it right out of the oven and you touch it, you're going to burn yourself because it is hot. Now, you take that cherry pie out of the oven, you put it on top of the stove. Does it always stay 350? What happens to it? Cools down. It cools down to room temperature. Actually, it happens pretty fast, within a couple hours. Room temperature, 1. You take ice cream, vanilla ice cream to go with that cherry pie, and it's in the freezer. And it's hanging out at about 0 degrees, right? Because it's ice cream. When you take that ice cream out, and when you first take it out, it's cold. Leave it on the counter. What happens? It goes to room temperature. So our principle here is room temperature always wins. Got it? Room temperature always wins. Now remember, we have to be above what to live? At what point are we dead? 92. Room temperature in this room right now is probably about 75 degrees. Okay? Room temperature always wins. If my body has to stay above 95 just to survive, right? So I'm not in hypothermia, and the room temperature is 75, there's a problem there because room temperature always wins. Everybody with me? Okay? I know this is science. Science is hard. I get it. But this is the point. Your body is constantly at war with room temperature. Room temperature is always trying to lower your body temperature to whatever the temperature is in the room. Always. So that means in your body, you have to have a mechanism to create heat to keep you above 95 degrees. And that is why you eat. Because when you eat, you burn calories. Anybody ever hear that term? Burn calories? That is a term that we use on purpose because that's exactly what it does. Your body uses those calories to create heat to keep you above 95 degrees. Now, this is an ongoing process. It never stops because if it stopped and your body temperature went down because room temperature always wins, you would die. Remember, 92, you're dead. So your body has to work really, really hard to keep your body above 95 degrees. Everybody understand that? Your body does not want to work that hard. It doesn't. It's tired. So when we're young, we have this nice wetsuit on. That wetsuit of fat helps hold in that body heat that your body is creating. So your body doesn't have to work as hard to maintain that temperature. So it also helps keep outside temperatures out. So if you go out in the snow, your body temperature isn't going to plummet because you've got a wetsuit on that helps insulate you from that outside temperature. When you go to the beach and it's 100 degrees, you don't suffer heat stroke immediately because you've got a wetsuit that helps regulate that and keep the outside temperatures from influencing your insides. Good? So our fat is actually a really important part of temperature regulation. But I just told you that as we age, we lose that layer of fat. So that means that our older individuals are going to feel outside temperatures way more than we do. How many of you guys have ever heard an old person say, yeah, I can't be up north. I can't handle the cold anymore. This is why they don't have the same fat protection to help prevent those outside temperatures from affecting them so acutely. Does that make sense? But they're also getting older. They're winding down. Their body doesn't want to work as hard. It's not as efficient. Their digestion system, which is what burns food to create heat, it's not working as well as it should. So one of the things that older people often do is because these systems aren't working effectively, they don't have the fat layer, they don't have everything working at peak performance, they tend to get cold because their body temperature falls. How many of you have ever walked into a facility and saw all the old people in sweaters and you're thinking, oh my gosh, it is not cold in here? And Martha's like, I'm freezing. This is because this system is not working like yours. It's why grandma's house is 86 degrees when you go in there and she doesn't want to turn the air on. It's because she does not have the same temperature regulation system that you do. Does that make sense? Pretty cool, huh? Okay, so this whole system is actually going to affect how they perceive water temperature as well. So when we feel the water with the inside of our wrist and it feels warm and we think, hey, it's fine, we're going to take it to our patient and have them check it as well. Because if they say, oh no, that's too hot, we're not going to argue with them. We're not going to say, oh, I checked it, it's fine. You're just being a drama queen. No, they are perceiving this temperature different than we do because their bodies are completely different than ours. Does that make sense? Good. Okay. So remember that layer of fat helps the outside temperature stay outside, the inside temperature stay inside. And as that layer of fat decreases, we're going to have a whole lot more effects on the patient based on the environmental temperatures. Okay, so we're going to have the patient check the water. We also, if we're taking too long to do this and the water gets cold or soapy, we're going to change that water too. So we want to pay attention here. Good? Questions? So the order matters. Whatever we wash, we rinse. Whatever we rinse, we dry. Now, I know that I keep going over that, but I know, based on 15 years experience of doing this, that you guys will forget to rinse. You will. Because you're all up in your head. It's just the fact of nature. So when you're doing washing skills, I actually want you to say inside your brain, whatever I wash, I rinse. Whatever I rinse, I dry. And if you do that with each step, whatever I wash, my next step is to rinse. Whatever I rinse, the next step is to dry. If you do that, I know it sounds super simplistic, but if you do that, it will keep you on track and you won't forget. Okay? Remember, everything that I do is designed to simplify all of the steps and make them easy to repeat. Good? Questions? All right. This is a picture of what happens when soap gets left on the skin. This is under a microscope. Those soap particles actually dry out the skin. It causes flaking, itching, and it can actually separate. You can see how the pores are, the creases are enlarged. It can actually separate the skin. And now we've got openings that pathogens can intrude into. So we're going to change the water if it becomes soapy or cold. That way we have water to rinse and we don't leave soap on the skin. Good? Questions?
I do have a question.
Yes.
So, if you take a bath, would it be appropriate or most likely more
If you're taking a bath, you should rinse off after the bath.
turn the shower on? And,
Yeah, because if you take a bath and if you take a bubble bath and you just get out of the bubble bath and you still have bubbles on you, that will dry out your skin.
Unless it's a product that has
Moisturizers in it,
Right.
but even still, it can
even
be.
for babies in a baby bath, for instance, baby wash is designed. Does
It
it
should
have to be rinsed?
It should still be rinsed.
So you're supposed to rinse your baby after you
Yes.
get him out of that little tub? Oh my
Yes.
goodness. My child survived it though. I didn't know that.
Yeah.
Thank you.
Yeah. Otherwise, it's interesting because babies can't really tell you that they're itchy or uncomfortable, right? But once you're aware of this, you'll be aware of it now. If you bathe baby and a couple hours later they get really irritable, chances are it's because they have soap on their skin and it's itchy.
I'm so old. I had a nurse come to the house when my son was born. That's how old I am. Because that's what the county did when you had a baby back then. That nurse never told me to rinse that baby off.
She didn't take my class.
I apologize.
She didn't take my class.
No, exactly.
Yeah, we should be rinsing soap off of everybody, because it does dry. Even moisturizing soap, the soap itself, the soap product itself, even though it's a moisturizing soap, should still be rinsed off the skin. Yep. Good. Try not to get your surface wet. So remember we talked about barriers. I told you when you use a barrier, the absorbent side should face up. You guys remember that? Well, that's because if we spill water, we want that barrier to be able to catch water so it doesn't drip on the floor. But if it does, if we get water on the floor or the bed or the table or anywhere else, wherever we're washing, make sure you clean it up. That's an important principle. You wouldn't want to just leave water on the floor after you're done with the skill and say, my skill is done. Why? Sure, absolutely. It's a slip and fall problem because now we got a slippery surface. But if you remember, we talked about washing hands on the first day. You guys remember that? And I said that pathogens need 3 things in an environment to thrive: warm, dark, and moist. That's right. So if we have water on the floor, and in a clinical setting, we know there's pathogens, right? It may not be warm and it may not be dark, but it's still moist, and pathogens that are in the area can use that moisture to its advantage. So we don't want to leave moisture on the floor or on the sheets or anywhere. We want to make sure that we're leaving the patient in a dry environment. Good? Good. Are you guys starting to see that things that I told you on day 1 are still relevant? Okay, so if we apply lotion, we're going to warm it up in our hands. Now, a million years ago, when I first started in nursing, we used to throw the lotion bottles in our basin to warm them up. So we had warm water in the basin, throw the lotion in there to warm the lotion. Well, the problem was every time I'd squirt the lotion out, it was never warm. And it took me a while to figure this out. Well, if you put a bottle of lotion in the warm water, first of all, it's not hot enough to really penetrate. But if it does, it's only going to penetrate on the very outside. If you look at a lotion bottle, we got a lotion bottle here, right? If I put this in here, all that's going to be warmed up is the very outside of this lotion. When I do this, it's not the outside of the lotion that's coming out, it's the very middle of the lotion, which did not get warmed. Make sense? So we don't warm our lotion up by throwing it in the basin. The other issue with that is infection control. I don't want anything in that water that I don't put there. That's how I keep the water clean. So don't put the lotion in the basin to warm it up. The best way to warm up lotion is to get a little lotion in your hands and rub it together. That is the best way to warm lotion. You're using friction in your body heat. And then you apply it to whatever surface needs to be applied, we need lotion on. And then once we've applied lotion, can you guys see this? Can you see the lotion on my hands? You see how it's shiny? That is a slippery surface. My skin is only going to absorb so much before it's saturated. Anything left is just going to sit on the, and you guys saw I did not use a lot of lotion. So I have lotion that's just sitting on the surface of my skin. If I go to pick up a cup of hot coffee right now, what's going to happen? Yeah, it's going to slip right out of my hands. Is that safe? So when we put lotion on a patient, we warm it up in our hands, we apply it to whatever body part we're going to apply it to, and then we wipe off the excess with a towel. Whatever the patient needed to absorb, they've absorbed. Does that make sense? You have to wipe off the excess after applying lotion. So I'm going to wipe off the excess. Okay. Any questions on washing rules? So let's review these all together. Basins are no soap zones, so we don't add soap to the basin, just water. We're going to use a paper towel to turn the faucet on. We're going to use warm water only, not hot, not cold. We're going to check it, and who else checks it? The patient. Whatever we wash, we rinse. Whatever rinse, we dry. We don't want to get our surface wet, and if we do, we're going to dress it. And if we're going to use lotion, we'll warm it up first in our hands, apply it, and then what do we do after we apply it? Wipe off the excess. Now, I know that there's a step here, step 5, I did not go over. We will be going over that later on in class. Not today, later on in the program. Okay, so there is another step to washing rules, but we're not there yet. Good? Questions? Okay, so now let's talk about the actual hand and nail care process. So now that we know all the steps involved, we know to do we know to read the care plan, to do the opening, use a barrier, evaluate gloves, not hold linens against us. We know our washing rules. We know how to clean the basin because we clean all basins the same way, and we know how to do closing. So now let's look at the specific steps for this skill that are relevant. So we're going to soak the hand in water. Doesn't matter how long. Soak the hand in water. And that just loosens up any debris that's underneath the nails. But it's also, we want to wet the skin before we wash it, just like you do in the shower. So we're going to soak the hand in a basin. Whatever we wash, we rinse. Whatever we rinse, we dry. There's no specifics here, guys. Just wash the hand. Nobody cares how you do it. Just wash the hand. We're going to put it back in the basin to rinse it. Because remember, the basin only holds water, clean water. Nothing else is ever in the basin. It's just clean water. So we'll put it back in to rinse. And then once we've rinsed, we're going to take it out and lay it on a towel to dry. You want the patient to be comfortable. Those tables are stiff and not overly comfortable. So put their hand on a towel to make it more comfortable. We're going to dry all areas. Then we're going to clean under the nails. We're going to use this orange stick thing here. It's called an orange stick because it's made out of orange wood, which does not splinter. That's kind of important when we're shoving it under somebody's nails, right? So we're going to use the slanted end, not the pointy end, the slanted end. And we're going to use it like a scoop. We're going to put it under the edge of the nail, circle it around. And now I've got stuff on that stick. Do I want to put that stick under the next nail? No. I'm going to wipe it off on the towel and then move to the next nail. Clean under the nail, wipe that on the towel. Move to the next nail, clean under the nail, wipe it off on the towel, and so on. Then I'm going to take a nail file and I'm going to file in one direction toward the center. Now, CNAs do not use nail clippers. Those are advanced pieces of medical machinery you are not allowed to touch. CNAs do not use nail clippers because the chances of you clipping the skin next to the nail are very, very high. So you do not use nail clippers. But the thing is, if you file the nails on a regular basis, once or twice a week, they'll never get long enough that you need to clip them. This is preventative maintenance that is way more effective than letting the nails grow, clip. Okay? That's why hand and nail care is done. So we're going to file in one direction toward the center. Now, as we age, our nails get brittle. As we age, our nails get brittle, and they're likely to split if we don't do this properly. Now you probably, everybody knows what this is, right? Nail file, emery board, whatever you want to call it. When you file your nails, you probably take one of these and go really fast. That one's missing a part. Go really fast along the surface of the nail. We don't want to do that because if we have a patient that has brittle nails, when we go like this really fast, it pulls the nail, pushes the nail, pulls the nail, pushes the nail, pulls the nail, pushes the nail, and it will split right up the center. So when we have a patient who's older and we have to file their nails, we only want to file in one direction toward the center. So it would be more like this. And this side, like this. And then across the top. Okay, good? Questions? So we soak the hand, we wash the hand, we rinse the hand, we put it on a towel and dried the hand. We cleaned under the nails, wiping it in between each nail, and then we filed in one direction toward the center. Once we've done all of that, we'll get some lotion, rub it in our hands, put it on the patient's hand, wipe off the excess, and then we'll do our closing. That's it. Okay? Good? Good? Okay. So, Amy, can you play the hand and nail care video, please?
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with a barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make sure it's okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. You're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Okay, remove from stage. There you go. Thank you. All right, so in your white book, you brought up a very good point. I'm sorry, I forgot to show you the care plan for this one. Go to page 117, and let's read the care plan for this skill. So at the top of page 117, you'll see the care plan. This is the testing care plan. The care plan reads, provide hand and nail care to one hand. What if the patient has two?
That's what the care plan says, so you just do one.
We're just going to do one. For the test, it's not going to tell you which hand to do. You get to pick. It just says one hand. In a clinical setting, it's not just going to say one hand. If they only want you to do one hand, it would specify which one. But the test is going to leave it open. Okay. And this is because if the patient has an incision on one hand, you're probably not going to wash that hand. That would be the nurse's job. If they have a cast on, you won't be able to wash that hand. If it was amputated, it's not there to wash. There's a lot of reasons why we would only be washing one hand. Okay, we're going to follow that care plan. It says the patient is sitting in a chair at the bedside and can move as directed. Okay. Good catch. Sorry, I forgot to read you the care plan before I showed the skill. All right, any questions on that one? Any questions? All right. Let's go ahead and take our break. Yep. Come back in 15 minutes. My timer is not working, so come back at 5 till. Come back at 5 till. Any questions so far? Am I going too fast for anybody? No? All right. So we are going to go to page 141. Okay. So change and occupy bed, that's a skill we're going to learn. I know the AC should, we'll see if it works. I just reset it, so hopefully it'll start cooling down. So the principles that are involved, there are a whole bunch of them. This looks very complex. It's not, everything you need to know already to do the skill. With the exception of one thing I've got to teach you. That's it. All I've got to teach you is one thing for you to know how to do the skill. We know to follow the care plan. Every skill starts with the opening. We're going to evaluate if we need gloves. Now remember, if we're going to touch body fluids, personal skin, or non-intact skin, we need gloves. For this skill, for the test, you were the patient. You're fully clothed. You're holding on to all of your own body fluids like a champ, right? And you don't have any open areas, right? I'm talking about her, not some fictional patient somewhere down the road. She is my patient. So if the answer is no to all of those things, do I need gloves? No. Now, in a clinical setting, if my patient is laying there in a hospital gown and nothing else, and I might come near their bottom half, do I need gloves?
Yes.
If my patient is incontinent, do I need gloves? Yes. If my patient has an incision and I have wound drainage on the sheets, do I need gloves? Yes. So we're going to evaluate this by patient, not by skill. Got it? Okay, so we're going to evaluate gloves. We need supplies, so we're going to have a barrier to put them on. Our patient is uncovered for this skill, so I need a privacy blanket to help protect their privacy. I'm going to be using linen sheets, so I don't want to hold them against my uniform. We're going to learn scoot and roll in just 1 second, and we're going to do the closing at the end. These are my skill-specific steps, which we're going to get to in just a minute. If you look at the bottom of the screen here, you'll see that this skill should take somebody with your level of experience 14 minutes or less. It's going to be done on a real live testing student, one of you. That person will be in bed, and charting is not required. I do have a video for this, and I've got the short version of the skill here. But if you turn the page to page 142, you will see all of the steps involved. And if you look, 142, 143, there are 44 steps to this skill. OMG. 44 steps. That's a lot of steps. And some of you might freak out a little bit over the fact that there are 44 steps to memorize here. Remember, you already know 90% of these steps. You know to read the care plan. Step 2, 3, 4, and 5 are all the opening. Step 6 is barrier rules. Step 7 is linen rules. Are you starting to see you already know these steps? So don't get caught up in the number of steps. You already know most of them. But I do want to focus on one of the principles that's going to govern how we do that. And that's right here. Right here. Clean rolls toward me, dirty rolls away. Amy, can you please make a note, page 84, just put on there page 84, page 84. Page 84? Yeah, just put that down for me, please. Thank you. Yeah. All right, so clean rolls toward me, dirty rolls away. What that means is that when we are changing anything from clean to dirty, okay, or dirty to clean, either way, there's a very specific way we're going to do that. And let me give you an illustration that explains how this works. Okay. So if I have, you guys can all see this, right? If I have a sheet on the bed, a bottom sheet, I got a patient laying on my bottom sheet. Good? For illustration, everybody good? I actually need a Barbie doll here. We'll use a pen. So I have a sheet or a patient laying on a sheet. The sheet is dirty. I've got to change it. This part of the sheet is dirty, but the underside that's on the mattress, not so much. So when I go to change the sheet, I'm going to roll it toward the patient. So the part that's facing up is the underside of the sheet. Good? Now, when I go to put the new sheet on the bed, I've got a new sheet and it's clean. I'm going to roll it toward me so that the underside of the sheet is what's facing up. So I'm going to put this underside under this underside, and that prevents direct transfer. Got it? So clean rolls toward me, dirty rolls away. Good? We're going to use this and lots of skills coming up. It won't be the last time you see it, but it does apply to changing the sheets. Clean rolls toward me, dirty rolls away. And that's how we prevent what we call gross pathogen transfer. Okay, stuff from the top side of the sheet getting on the top side of the new sheet. But here's the problem. You know what's still in the bed? The patient. Yeah. This isn't a sterile process by any stretch of the imagination. The patient who was laying on the dirty sheet is now laying on the clean sheet. So it's not that we're trying to sterilize this environment. We're just trying to change sheets, people. Okay. Now, if this sheet is soaked through, okay, we got wet stuff. It is soaked through. Well, when I roll it away from me, I still have stuff here soaked through. I don't want my new sheet wet. That's just kind of gross. So what I would do is take a barrier that's waterproof, remember? And I would wrap the wet area with that barrier so that when I put the new sheet on the bed, the new sheet is not getting contaminated with the wet. The barrier is protecting it. Good? Questions? Pretty easy, right? This skill, this is one of my favorite skills. It's a Houdini skill. Presto changeo, the sheets are clean. It really is kind of it's a physical skill. Oh, physical. But it's kind of a fun skill, especially at parties. Get your $25, I can change that sheet and you don't have to get out of the bed. Great way to make some extra money. All right. Questions? Okay, so clean rolls toward me, dirty rolls away. But there is a new principle we have to learn here. So this is one of the last principles that we're learning. So if you remember the back wall, right? I told you we're going to learn all of that by the end of the second week, right? Well, we're in the second week. We know skill rules. We know the opening. We learned the barrier and glove rules. We know when to use a privacy blanket, and we know how to treat linens. We've learned washing rules this morning, and we know how to clean basins. We also know the closing, right? So there's only 2 principles left to learn: scoot and roll and shoe rules. That's it. We're making good progress. And it really wasn't all that hard, was it? So we're going to learn scoot and roll now, and we'll learn shoe rules a little later on in the program. So this, what I just told you, is in linen rules. And if you remember when we learned linen rules last week, I actually had these covered up so you couldn't see them. So this is what we are focusing on now. Clean rolls toward you, dirty rolls away. Don't let clean or dirty linens touch the floor. Nothing touches the floor. Any questions? All right. So this is a visual example of what I just showed you with the washcloth. Clean rolls toward me, dirty rolls away. So the clean sheet would roll toward me, the dirty sheet will roll and tuck under the patient. And that's how we help prevent that pathogen transfer. You don't want anything to touch the floor. Ever. Not clean, not dirty. If it touches the floor, we got to get rid of it. Don't use it. All right, so when we take linens off of the bed, we have to put them somewhere. If they can't touch the floor, and that's what we do at home, isn't it? I change my sheets at home. I pull the sheets off the bed. They go right on the floor. And then I bundle them up, take them to the washing machine, and wash them. But when we take our sheets off at home, they go on the floor as we make the bed. We can't do that in a clinical setting. Not allowed. So if we can't put them on the floor, what do we do with them? So we have to put them in something. Ideally, it would be a hamper. We have one over there. Ideally, a hamper. The problem is that we don't keep hampers in patient rooms because we don't like dirty things in clean environments. So that hamper will probably be in the hallway or in a specific room called a soiled utility room. If we don't have a hamper in the room, our next option is to go get a bag. And we have special bags that are actually stamped soiled linen. Go get a bag, open it up, put that on the floor. You can put the linens in the bag, no problem. If you don't have a bag, at least use a chucks on the floor. Okay, but we got to have something between our linens and the floor. Good? Good? Okay. So in most clinical settings, we have a special room called soiled utility. Now this special room, let me see. I just want to make sure that, yeah. So we have a special room called soiled utility. And in that soiled utility, we have everything that we consider dirty. So you'll have like lunch trays that are left over that didn't get picked up by dietary in there. You'll have soiled linens in there. You'll have dirty bedpans that need to be cleaned in there. We usually have cleaning items in there as well. Sometimes we'll have a toilet in there, but most of the time it's going to look like a modified toilet, kind of like a toilet with no seat. It's a little bit more square. Definitely not going to fit your backside. It's too big. And a lot of people wonder, what the heck is that? It looks like a toilet, but it kind of doesn't. What is that? It's actually for cleaning of soiled items. It's a specialized type of toilet that has like a shower head that sprays into it. And if we have linens that maybe have fecal matter on them, we rinse the linens out in there before we put them in the bag. So we're not putting fecal matter in our washing machines. Does that make sense? You'll hear them called hoppers. That's the most common name for them. Some places call them Johnny hoppers. I'm not real sure where that name came from, but you will hear that as well. But most places call them hoppers. You will always have a sink and soiled utility as well. Please don't put biological material in the sink. That would have to go in the hopper. Good? Every soiled utility room will also have a biohazard. Let's talk about biohazard really quickly. Very, very short description of this. Follow your facility policy when it comes to biohazard. Let me say that again. Follow your facility policy when it comes to biohazard. Generally speaking, unless something is dripping with contaminated biological material, it cannot go in a box. It has to be dripping. If it just has urine on it, we can wash that. Okay? Does that make sense? Follow your policy. Unfortunately, a lot of people, remember we talked about throwing bedpans away last week? Remember that? Okay. So a lot of people would rather throw something away than clean it. It's easier. Just throw it away, out of sight, out of mind. But that doesn't really solve any of the problems. So a lot of people think about biohazard the same way. Well, if I just throw it in that box, it goes away. I don't have to worry about it. But it costs the facility thousands of dollars to have the items in this box processed. Thousands of dollars. So you need to go by your facility policy as to what gets to go in here. Most items, almost all items that we use with patients, linens, can simply be put in a hamper and washed. Okay. Good. Questions? Soiled utility is usually where you will find those bags that I was talking about, the soiled linen bags. Soiled linen bags, they're kind of unique. Anybody know what Tide Pods are? You know, those little pods you throw in the washing machine when you do your laundry? Well, those bags, they're light blue in color. They're super, super light, like baby blue. And they'll actually be stamped soiled linens. Those bags are the original Tide Pods. We've been using them for 40 years. And anything that's in that bag is going to go into the washing machine because the whole bag goes in. The bag breaks down and becomes the soap, the detergent, or whatever we're washing. Well, if you don't pay attention when you're changing the sheets, and hearing aids get wrapped up in that sheet, if dentures get wrapped up in that sheet, if cell phone chargers, earrings, pens, you'd be surprised at all the stuff that ends up in sheets. Nobody is going through those sheets to remove those items before they go in the washer. You put the sheets in the bag goes in the washer. Nobody in between. So we've got to be careful when we're changing linens to make sure that there are no foreign objects that can ruin the washer or get ruined by the washer. Okay, good. Now the reason for that, guys, this is sad. This is so sad. Laundry people, the people that do laundry, they're not highly skilled. There's no class they have to take. It's a minimum wage job, usually done by people who don't want to do the job, right? So they have a higher incident of needle sticks than nurses. Higher incident of needle sticks than nurses. And that's because needles often end up in those sheets. So in order to help prevent that, these bags were created so that they aren't responsible for shaking out the linens and possibly getting stuck by sharp objects. Okay. Make sense? I think that's super sad. I mean, that's a risk that they didn't sign up for. We've got to get better than that. So with our linens, we know to use it or lose it. If we take too many, where do they go? In the hamper, in the dirty linen. Absolutely. All right, so here's our new principle to learn for this one. It's called scoot and roll. And we're going to simplify this. Patients need to be in the middle of the bed at all times, period. End of discussion. That's really all I need to say here. Patients need to be in the middle of the bed at all times. Now, some people think that you need side rails to keep a patient safe while you're doing skills. And that is actually further from the truth than you can shake a stick at. I mean, it is, you do not have side rails to keep your patients safe. In fact, they don't keep your patients safe. If you turn a patient over and they're pressed up against that side rail, if that side rail fails, there's nothing to keep them from tumbling out of bed. It did not keep them safe. Side rails do not keep patients safe. Even worse, a lot of times we use side rails because our patient is weak and a fall risk. If I've got a patient who's a little unsteady on their feet, maybe medicated, maybe a little dizzy, maybe has dementia, and they're unsteady on their feet, I don't want them up walking around because I don't want them to fall. Sounds like my heart's in the right place, doesn't it? It's not. I don't want them to fall because I don't want to do the paperwork. It has nothing to do with them. And I'll prove it to you. If you have a patient who is not allowed to get up and walk because they're unsteady or dizzy or any of the above that I mentioned, right? We put them in bed and put side rails up to keep them there. That doesn't do anything to improve their condition. Nothing. In fact, patients that are in bed for an extended amount of time will end up in worse shape because they get weaker. Their muscles atrophy. Their joints fix in position. their balance and coordination is affected because of no use. So when we put a patient in bed and put the side rails up in the name of safety, we actually are putting our patient further at risk. Because the only time they're going to discontinue using those side rails is when the patient goes home. And now we've got a weaker patient outside of medical help. Did that help them at all? Side rails do not improve patient outcomes, period. And because of this, because it doesn't improve patient outcomes, most facilities don't even have side rails on the bed. Not even there. In order for me to use side rails as a nurse, I have to call a doctor and get an order, and that doctor has to come in and physically eyeball that patient within 4 hours of giving me that order. No excuses. They have to come in and physically eyeball that patient. So if I get an order, I have to call maintenance, come put side rails on the bed. They're not even there. And that's because we can't trust you, especially on night shift and on weekends, because we know you'll put the side rails up to keep your patients in bed so you don't have to work so hard. And that's horrible. But that's reality. So there will not be side rails on the bed in most settings. But we don't need them. As long as your patient is in the middle of the bed at all times, you don't need side rails to keep them there. So I need a volunteer, somebody to come lay down in this bed. I need a volunteer. Thank you.
Can I take my shoes off?
No, you can leave them on. It's fine. So just lay down in the bed. All right.
Let me push the emergency button. Oh, it's not working.
Okay, hold on a minute. Why is this not? Okay. Now I can turn this. All right. So I asked her to lay down in the bed. Where did she put herself? Where did she put herself?
In the bed.
In the middle. Did I tell her to put herself in the middle? I just told her to lay down. Why did she? No, she knows she's not staying in this bed. She knows she's getting out of the bed very shortly. So she's not here to stay. This is a short-term thing. Why did she put herself in the middle of the bed?
More comfortable?
You told her to?
Safety.
No, I didn't tell her to.
So she doesn't fall.
Okay, so she didn't fall. Safety. Her brain told her the safest place for her was in the middle of the bed. I didn't tell her to do that. Her brain did. Do you know who else has brains?
Patients.
Our patients. That's right. That is built into them. And this actually starts happening when you're about 1.5 years old. You develop something called spatial awareness. Now, up until you're about 1.5 years old, you're in a crib. That crib is designed to keep you confined. But as soon as you figure out how to work your body, what happens to you staying in the crib?
Crawling out.
Not falling out,
Crawling out.
crawling out, climbing out. Yeah, you realize real quick, hey, wait a minute. I have the ability to get out of this position. And you do. You crawl out of the crib. But now, instead of falling from a height of this, you're falling from a height of this, which means you're probably way more likely to get injured. So mom sees this and mom thinks, okay, that's not safe. You're crawling out of the crib. Time for a toddler bed. So mom puts you in a toddler bed that's super close to the floor, and she probably put something soft on the floor just in case you fall out, like a blanket or something, and you learn how to sleep in that small bed. This is the beginning of you learning spatial awareness. And you're going to take this spatial awareness with you for the rest of your life. The really cool thing about spatial awareness is it is always on. It's a little part of the brain that's always on, even when you're asleep. There's only 2 times it gets turned off, and we'll talk about that in a minute. But this part of your brain is always on, doesn't go to sleep. So even when you're asleep, laying in bed, you don't stay in this position, do you? You toss and you turn, and you don't fall out of bed. So how do you toss and you turn when you're sleeping and not fall out of bed? It's because that little piece of your brain is on and is aware of where you are in relation to the space you have to work with. So let me illustrate this. Can you turn toward the window for me? Can you roll over so you're toward the window? Facing the window. Okay, I asked her to roll over, right? Did she roll?
No, she moved that way first and then.
Yeah, she shifted and rolled. So where is she? Still in the middle. I didn't tell her to do that, did I? Why did she do that? Why didn't she just roll? Yeah, because her brain told her that is unsafe. That is right. She would fall. She did not want to be on the edge of the bed. I did not tell her to do that because she has a brain that told her that is not safe. This is. Do you know who else has brains? Your patients. That's right. So you are not going to have to tell your patients to do this. Your patients will keep themselves in the middle of the bed without your help. They don't need your help for this. They've been doing this since they were 1.5 years old. They're in good shape. Now, I told you there were 2 things, though, that affected this. One of those is medications. The other one is alcohol. This is why you can start out on a bar stool at the beginning of the night, but by the end of the night, you're having trouble maintaining that balance, right? Alcohol affects this. Alcohol puts that little area to sleep. It's why you're more likely to fall out of bed when you've been drinking heavily, because that part of your brain is asleep. The other thing that can affect it is medication. So as a nurse, I know this. So I know if she's on certain medications, this may be a problem. So I would put instructions in the care plan on how we're supposed to address this. Good? Make sense? Okay, back on your back for 1 minute, please.
It's got a question.
Yeah. All right, so if we have a patient who's in the middle of the bed and I know that their spatial awareness is affected and I have to turn them on their side, I can't just come over and turn her on her side because she's going to be on the edge of the bed and that's not safe. You know that, I know that, she knows that. So in order to get her in the middle of the bed after the turn, we have to do what she did. We're going to shift and then roll. Or in this case, scoot and roll. So can you scoot your whole body toward me? Stay on your back, but scoot your whole body this way. Okay. And now can you just roll in that direction? Without shifting, just roll. Yeah. So when we do that, when we scoot and then roll, do you see how she ends up in the middle of the bed? Good. So anytime we're working with patients and we have to have them in the middle of the bed, but on their side, we're going to scoot them toward us first and then roll them away from us. Now, there's an important principle here. We need to remain behind the patient's behind. We do not want to turn a patient toward us. There's 2 reasons for that. First is safety. Most of her weight distribution is back here. So gravity is always going to try to pull you back onto your back. That's just a gravity principle. If gravity gets a hold of her, it's going to pull her onto her back. If I'm in this position, I can help control that because I'm in the same area as her, the predominance of her weight distribution, okay? Just stay there. If I turn her toward me and I'm here, if gravity is pulling her in that direction, I then have to stretch to try to prevent that from happening. And I'm much more likely to injure her or myself. It's too far. Make sense? The other reason you never want to turn a patient toward you outside of safety is that, and there's no easy way to say this, guys, I hope I don't offend anybody, but you never want your patient to be eye level with your crotch. I mean, that's reality. That can be very, very threatening, especially if your patient is feeling vulnerable or if they've ever been a victim of a sexual assault. This can be a triggering position. Never turn a patient towards you. Thank you. Yes. Okay, so we're not going to have side rails in all settings. Remember, they require a doctor's order. We're going to have the patient scoot toward us and then roll them so they're facing away from us. We remain behind the patients behind. Oh, thanks. And, sorry guys. And, there we go. Thank you. So we're going to remain behind the patients behind, and the patient must always be in the middle of the bed. Doesn't matter whether on their back, their side, upside down, doesn't matter. Your patient needs to be in the middle of the bed at all times. Let me talk to you about side rails real quick. Side rail, this is a legal principle, guys. No one has the right or the authority to impede on your freedom of movement once you're an adult. Like, I can't come over here and grab you and tie you to that chair. Even though you're in my classroom, I don't have that right. You're an adult. You have the right to get up and walk out that door anytime you wish. I don't have the right to tie you to this bed. You're an adult. That doesn't change even if you're in a medical facility. There's only three types of people that can restrict your freedom of movement. And two of those are temporary. There's only three types of people. Number one is a police officer. Police officer can handcuff you and put you in jail, but that's temporary. Who do you have to go see? The judge. The judge is the only one that can make it permanent or long-term. The other person that can restrict your freedom of movement temporarily is a physician. But it's temporary. Who do you think they have to go in front of to make it longer term? A judge. Correct. Did I say CNA anywhere in there?
No.
Did I say nurse anywhere in there? No. There's only three people that can interrupt your freedom of movement. Law enforcement, physician, those are both temporary. In order to make it longer term, it has to go in front of a judge. Do you guys understand that? We cannot use side rails just because we think that it's appropriate. Good? Did I get you to think about that a little different? Now, way back in the day, when I was a brand new nurse, we used side rails for everybody. Everybody. You didn't walk away from that bed until the side rails were up. So those of you who have been in medicine a while, this is going to be a change for you. New people don't know that, but it's going to be a change. Okay. Yeah, you should have seen that when they enacted this, man, the nurses were all up in arms. This was a big deal. Big deal. But when you think about it, you're not doing that patient any favors. Sure, we're helping them not fall, but we're going to cause them to fall once the restriction is removed, and nobody's going to be there to help them. And that doesn't help. Okay. So remember that side rails restrict a patient from getting out of bed. This makes them a restraint. This, guys, is a written test question. You will have a written test question on restraints. Side rails are a restraint. You need to know that. They don't keep your patient safe. Staying in the middle of the bed does. Side rails are a huge safety risk, though. Do you see this? Patients that have side rails up, they're not going to stay in bed just because you want them to, any more than that 1-year-old is going to stay in a crib because you want them to. If they want to get out, they're going to get out, which means they have to go over, under, around, or through those side rails. And this has killed more patients than any slip and fall. This is real. There are real patient photos of this happening online. I made a cartoon because I'm not going to show you a real patient photo. This is real, and it happens way more than you think it does. Side rails are extremely dangerous. Let me explain why. Let's say that I just had a gallbladder surgery and I'm on, coming out of anesthesia. I'm a little unsteady and they want to keep me safe. They put me in bed with the side rails up. As I come out of anesthesia, I'm going to have to pee because they pumped in a ton of fluids during surgery. I'm going to have to go to the bathroom. I hit the call light and I wait and I wait and I wait. Nobody comes. I hit the call light again and I wait and I wait and nobody comes. And now I've really got to pee, guys. It's like DEFCON 3. I've got to go. I got two choices. I can either pee myself in bed. That's a dignity issue that I'm not willing to do. Or I got to get around this barrier to get myself to the bathroom. Now, I'm probably hooked up to all sorts of stuff on top of that. IVs and not catheters, but IVs and all kinds of stuff. So me trying to get over this barrier with tubes and all that other stuff, much, much more likely that I'm going to injure myself. Those side rails did not keep me safe. Do you know what keeps patients safe? You answering the call lights promptly. That is what keeps your patients safe. When that call light goes off, you need to be answering it. I was in a facility not too long ago, and as I stood there waiting for the DON that I was going to be meeting with, I stood there and I'm looking down this hallway. And down the hallway are 3 call lights that came on in the 3 minutes I was standing there. 3 call lights. There's 3 staff members standing at the nurse's station talking about personal items. Those 3 call lights are going off. They're still talking about personal. Call lights are still going off. They're still talking about, nobody addressed those call lights at all in the time that I was standing there. I met with the DON. 10, 15 minutes. I come out, all 3 of those call lights are still on in addition to 2 more. And do you know where those staff members were? Still at the nurse's station. Still talking about personal items. You want to know how this happens? That is how this happens. I've seen it happen myself. Be careful. Your patients are depending on you. Call lights need to be answered promptly because on the other side of that call light is a patient that can't do for themselves what they need to do. And if you're not there to help them, they're going to do it anyway. Okay, good. Questions? Positioning rails are not side rails though. So this shows you this. You can see that on this bed too. The half rails at the top, those aren't side rails, those are positioning rails. They can hold on to those to be able to position themselves in bed, but it doesn't restrict them from being able to get out of bed. Their legs will still swing out. This is not a side rail. The minute we put these up though, that is a side rail. Okay. So over here, let me bring you over to this bed real quick. So this is a positioning rail. You will have these in most settings. They will still be on the bed. These are the ones that they have removed from the bed because this makes it a restraint. Positioning rail, perfectly okay. Restraint. Okay. All right. So to remain safe, the patient must be in the middle of the bed at all times, especially after they've been turned on their side. This is not safe. Melissa says, Miss, not all nursing home has call lights or bells. That's actually, if you're working at a nursing home without call lights, that nursing home needs to be reported. That is a function of nursing homes. That's that term, nursing homes. That means nurses are on staff and the patient has to have a way of calling nurses. Now, you may not have call lights in assisted living facilities because that's where the patient lives. It's apartment style living. So there may not be call lights there, but in nursing homes, there has to be call lights. That's a federal rule. You'll also have call lights in rehab centers and hospitals. Not in assisted living, not in home care. But yes, if you're working in a nursing home and there are no call lights or the call light system is broken, that is a major violation. Major. All right, so this is not safe. So we're going to scoot toward them so that they're in the middle after the turn. Okay. Always turn the patient away from you. So bed position, really quickly, there are a couple of different ways that we can position beds. Head of the bed, foot of the bed, entire bed. Head of the bed and foot of the bed, sometimes we have to adjust these to do the skills, particularly like mouth care. We put the head of the bed up for safety. Foot of the bed, we might want to elevate. I don't know if we're putting their socks and pants on, right? So you may use these two while you're doing the skill, but at the end of the skill, it's always patient comfort, whatever they want. Entire bed, though, this is the one that messes people up. We can raise these beds up to a comfortable working height for any skill that we're doing. So if I'm changing the bed, yeah, I might want to raise that bed up to make it comfortable so I don't have to bend. But when we do that, it's really, really important to understand what we're doing when we raise the bed. Let me show you this, because this is something that most people don't really think about. All right, so I've got this bed here. And it's in a low position. And most of you guys sleep in bed. When you go to bed, you sit down, you swing your legs in, you go to sleep, you wake up the next morning all groggy and you're not really thinking straight. You swing your legs out and that floor is always right where you left it. Never moved a day in your life. Floor is right where you left it. And your brain expects that floor to be right where you left it because it has always been right where you left it. But in a clinical setting, if I come along and put this bed up to change the sheets to make it more comfortable for me, and the patient goes to get out of bed, is that floor right where they left it? Are they going to expect that? No, they're going to swing their legs over as if the floor was there, and they're going to put their weight down and the floor is not where they left it. What's going to happen? They're going to fall. When we talk about raising the bed to a comfortable working height, what we're actually talking about is moving the floor. So if we get done with this skill and we forget to put the bed back down where we found it, it puts our patient at risk. This is an automatic fail on the state exam. If you raise the bed to a comfortable working height and you forget to put it down at the end of the skill, it doesn't matter how good of a job you did on the skill, you fail. Why? Yeah, we put our patient at risk. Yep. You guys see that? So for the test, leave the bed where it's at. Because at the end of the skill, you're going to be in a rush and you will forget to put the bed down. You will. You'll forget. Because you're going to get into your closing and you're just going to kind of roll through your closing and just try to get it done because you're so stressed out about the test. You will forget to put the entire bed down. So just leave it alone. For the test, just leave it alone. In a clinical setting, definitely use it because it will save your back. All right, so when we are changing sheets, when we're making an occupied bed, you want to keep your patient from laying on the bare mattress. So we're going to roll the dirty sheet toward the patient, tuck it up under them. We're going to put the clean sheet on the mattress before we roll the patient back over. You do not want to roll the patient onto a bare mattress. Okay, so here are our skill-specific steps. These are things that they're going to be testing you on. Keep the patient from lying on a bare mattress. We're going to replace the sheet on one side of the bed at a time. Clean rolls toward me, dirty rolls away. We've learned that. We'll remove the dirty bottom sheet and secure the clean sheet on the mattress corners. We want to smooth any wrinkles. Now, we're going to learn about that in a future episode, future lesson, but wrinkles contribute to bed sores. So we want to try to remove as many wrinkles as possible. There's a person in the bed. We're not going to get it perfect, but we want to do the best job we can. We're going to replace the top sheet. We'll make some hospital corners. I'll show you how to do that. We'll loosen the sheet over the toes, and we're not going to tuck the sheet in along the sides because that's going to restrict the patient. And then we'll replace the pillowcase. And we want to limit the amount of time they are without that pillow just for comfort. So our care plan on page 142 tells us to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. The resident can roll and move as directed, but cannot get out of bed. I'm going to stop there for a second. Anytime your patient gets out of bed, you should automatically consider changing the sheets. It is so much easier to change a bed with nobody in it. I can change an unoccupied bed in about 50 seconds. Less than a minute. I can strip this entire bed and make it in less than a minute. But if there's a patient in the bed, it's 6-7 minutes. Remember, they give you up to 14 to do this. So if I've got a bed that's empty, I walk by the bed and I see it's empty, there's no patient in it, I'm automatically thinking, do those sheets need to be changed? Because I'd rather change it when nobody's in it. But we have to learn how to change it when somebody's in it in case we need to. Okay. It tells us bedspread, blanket, draw sheet, and underpad is not required for this skill. Now, if you just look on page 143, it does tell you about a draw sheet and a chuck. So if you need one, it's not used for the test, but this tells you your process if you need to use one. Okay. Good. All right, Amy, can you play the video for me? Make occupied bed.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Questions?
You said the pillowcase needs to be like the opening part needs to be facing away from the door. Same thing.
Right. A lot of people walking up and down the hallway. A lot of visitors and staff members and patients, and they're all breathing pathogens out. So we don't want those pathogens to come in on air currents and have a nice, warm, dark, moist place to land. Because inside the pillowcase is warm, dark, and unfortunately patients drool and do all kinds of things on their pillow. So moist. So if you have the opening facing away from the door, it minimizes pathogen intrusion on the pillow.
So how clean are pillows?
They're not fabric like what you have at home. They're plastic covered. So generally speaking, they're wiped down by housekeeping in between patients because they have that plastic covering. Some places use disposable pillows where they're, the pillows themselves have like a paper covering to it. Just depends on the facility. But they're not fabric like what we use at home.
So how about the home pillows? Should we change it every year? Or can we wash a pillow?
Some pillows are washable, sure. And that's really just kind of your own. Remember that your pathogens are yours. In your home, you probably don't have a whole lot of strangers coming in and out bringing pathogens. Remember, in clinical settings, we have strangers with pathogens there. That's why it's more important. All right, any questions on this? Okay, I know we have respirations on the schedule for today, but I am going to move that to a future day, a little bit later on in the program, because I need to get into blood pressure. We need enough time to work on blood pressure. So we're just going to move respirations a little bit further down the road. I got some time in one of the future lessons to put that. So let's go to page 56. Okay, first thing I need to tell you about blood pressure, it is not on the state exam. This is not a skill that you will be asked to perform on the state exam. I still am going to teach it to you because it's important that you know how to take a manual blood pressure, but it's not something you're going to be tested on. Okay, to take the pressure off of you, it's not on the state exam.
Blood pressure is not on the state
Blood pressure
exam?
is not on the state exam.
When did they do that?
About 8 years ago.
Really?
Mm-hmm.
Oh, okay. Thanks.
Yeah.
Can I ask a question?
Mm-hmm.
Sorry. Is that because of them not the ones that the CNAs use now are
So there's two reasons.
okay.
Okay. So the first is most facilities are going to have you using an automated device.
Okay.
That's the first reason, is that manual blood pressures are usually done by an automated device in most clinical settings, but just because you're using an automated device doesn't mean that you don't know how to do a manual, because if that automated system gives you an abnormal reading, you have to double check it manually. So that means you still have to know how. So yes, it is done with automated devices in clinical settings, but the real reason that this was removed from testing is because it is subjective when it comes to testing. So my ears are pretty well tuned to blood pressure. I've been doing this for 30 years. I can hear things that you probably aren't going to hear as a newbie, right? So I'm going to get a different reading than you do. It's just the nature of the beast, because I'm advanced, you're beginner. Does that make sense? So it's really, really hard to gauge this objectively for the test. Okay. So that's the other reason that they removed it from testing, is it's just very difficult to grade it objectively.
Good.
Yeah. Yeah. That doesn't mean you don't need to know how. If you take my blood pressure with an automated cuff, you hit the button and it gives you a reading of 280 over 120. I don't want you to go report that to the nurse. How do you know that it's right? How do you know that the cuff didn't malfunction? You're going to go get that nurse all riled up, maybe for nothing. So you've got to be able to take it manually to double check it. And then if you get 280 over 120, then go get the nurse right away and watch her run. Okay, good? Makes sense? Okay, so the first thing you need to know is that it is not tested on the state exam. But you will have some questions on the written test about blood pressure. You have to know your normal values. So let's talk about what blood pressure is. So in your chest, you got a heart. I'm going to show you the Grinch, and it's two sizes too small. So you got a heart, and that heart squeezes. And when the heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. And that wave pushes the one in front of it. Do you guys remember this from Learning Pulse? So we've learned this before. So our heart squeezes and pushes out a wave. Now, when we took Pulse, what we did was count the waves. How many waves told us how many times the heartbeat. That was Pulse. When we're taking blood pressure, we're going to do something a little bit different with those waves. Instead of counting them, which was Pulse, instead, we're going to measure the amount of pressure inside the artery when the wave moves through and how much pressure is inside the artery in between waves or when the heart is at rest. So the way I want you to picture this, okay, let's make it a little bit simpler because this is complex. This is like, I don't get this, right? So let's make it a little bit simpler. So let's say that you have a faucet on the outside of your house, spigot, and you have a hose attached to that faucet. And you go out to the faucet and you turn the faucet all the way on. Water comes through the hose expands and gets bigger. It has pressure inside of it. You turn the faucet off, that hose shrinks down and gets squishier, less pressure inside. So all the heart is doing is standing in that faucet going on, off, on, off, on, off, on, off, about 70 times a minute for your entire life. It does not take coffee breaks. Your heart works nonstop. So on, off, on, off, on, off. Got it? So what we're interested in is, okay, when the heart turns the faucet on, how much pressure is in that hose? When the heart turns the faucet off, how much pressure is inside the hose? That's what blood pressure is. How much pressure is inside the arteries when the heart contracts? How much pressure is inside the arteries in between contractions? Now, same hose, okay? Outside in the Florida heat, for 10 years, faucet all the way on, all the time, never turns off. What do you think is going to happen to that hose? Okay, it actually, yeah. So we have stress from the outside. We have unrelenting pressure from the inside. Those two forces combine and they will split the hose. It'll actually split. Now you got to go to a big box store and get a new hose, right? At home, that's easy to fix. In a patient, we call that an aneurysm when it happens in our abdomen, or a stroke when it happens in our head. But the same forces are at play. Stress from the outside and excess pressure on the inside. So high blood pressure contributes to this. Does that make sense? Okay. High blood pressure makes us susceptible to aneurysms and strokes because of the stress from, guys, we live in a stressful environment. Okay. Everybody has stress all the time, especially in our current society. So we already have outside stress. When we have high blood pressure inside, it sets us up for some very, very nasty problems later on. So it's better for us if we can find high blood pressure and treat it early so that we don't have all that pressure inside our vessels and they're less likely to split later in life. Good? Make sense? So as CNAs, all we're going to do is run around and try to find some high blood pressure to report. That's all we're doing. If the patient has high blood pressure and the nurse already knows about it, yeah, that's not our job because CNAs do what they care. Remember this? CNAs do normal. So if the patient already has high blood pressure and we know the patient has high blood pressure, that's the nurse's problem. The nurse will be taking that blood pressure. CNAs do normal. So what CNAs do is run around and try to find high blood pressure to report. So what is normal? So top number or systolic number for blood pressure, normal is between 100 and 119. Okay, that's what we're looking for. Very few people in America over 40 fall in that camp. Very few. Used to be 100 to 139. We were a little better then, and then the American Heart Association said, nope, we're going to change it. About 5 years ago, gave 30 million people high blood pressure overnight. So this is normal, 100 to 119. If the top number is not in this range, we report it. Bottom number, 60 to 79. If our bottom number is not in that range, we report. Who do we report it to? The nurse. Okay, so those are our normal values. Good? So let's learn how we're going to do this. So those of you who have your blood pressure cuffs and stethoscopes, go ahead and pull them out. And we're going to start with the stethoscope. Okay, we're going to start with the stethoscope. So hold your stethoscopes up for me with the ear tips so I can see. Okay, you get to take a brief nap for 2 minutes. Let me see, 2 minutes like this. Okay, you can take a brief nap, 2 minutes, 2-minute nap. Stay awake, stay awake, stay awake. Stay awake. You see your stethoscope? Okay, you're good. You're good. You're good. Stay awake. Stay awake. You're good. You're good. Stay awake. Okay, so everybody know whether you're awake or sleeping, right? Right, the reason for that. Those of you who I told to stay awake, your earpieces are straight. Your ear canals are not. So we have to reposition our earpieces to fit our ear canals. The way that you do that is you hold down here at the little chin strap thing, and you just move your earpieces ever so slightly forward. Your earpieces should look like this. So you see how they are positioned forward. You guys see that? They're not straight. They are forward. There is a right and wrong way. Some of you, your earpieces came pre-positioned. That's why I told you you could take a nap. Now wake up, everybody. All right. So there is a right and wrong way to put these in your ears, and left to your own devices, you will always do it wrong. I don't know why everybody universally puts these in wrong. In our career, it's always about the all right. Your ear tips have to face the patient. It's all about the patient. Our ear tips face the patient. When you put these in, do not put them in this way. It's not about you, it's about the. All right. So what I want you to do is have these ear tips facing away from you and put them in and very gently tap your diaphragm. Okay. Now take them out, turn them around, put them in, and try it again. Do you see that there's a difference? Take them out, turn them back around so they face the patient, put them in, and touch your diaphragm again. It should sound way louder. If it does not sound way louder and you adjusted your ear tips, adjust them a little bit more. Okay, that's good. So good. Which way do your ear tips face? Toward the patient. Now down here, this guy, this is your microphone. That's what it is. Because I am listening to, oh, let's go back up. I am listening to a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound. I need a big microphone. We're going to use the largest diaphragm. Okay. The problem is this whole thing on most stethoscopes turns. The whole thing turns. The whole thing turns. I want the large diaphragm for blood pressure. So I have to tell this stethoscope which side I want to listen to. Down here, this little metal adapter piece probably has a dot on it. You want to make sure your large diaphragm is facing the same direction as that dot. Now, there's some of you don't have that. So, you have a dot, you have a dot, you have a dot, you have a dot. You do not. And that's because your stethoscope, it's only one-sided. So you don't have to turn yours. They're not going to flip around on you. You're good. Yours is you don't have a dot. Oh, you did. Okay. So you see that dot? You want the large diaphragm facing that dot. Yours is a Littman. You don't have a dot. So yours is a little bit different. For yours, this is a really good stethoscope. Don't lose it. Oh, you do. Wow, they put a dot on there. Nice. Okay, you do have a dot there. Usually you have to look inside to see if it's open. You have a dot. You're good. You have a dot. You have a dot. You do not have one. Okay. So, you can't see here. See that. So put these in. Which side is louder? But is it louder when it's facing this way or louder? Okay, so that is on now. Yours is single-sided. Sorry, guys. Okay. You have a dot. You have a dot. And you have a lip. You have a dot, right? Okay. All right. So the reason I bring this up is because when you go to put this stethoscope back in your case later on to take it home to practice on the unsuspecting public at home, you're going to fold your stethoscope up and shove it in this bag, and that diaphragm is probably going to flip over on you. So when you get home and you take your stethoscope out and you put it in your ears and you can't hear anything, that's why. Look at your diaphragm, make sure it didn't flip around. Good? Okay. So 2 most important parts of using your stethoscope. Make sure the ear tips are facing, okay, and make sure your diaphragm is set with a dot on the larger diaphragm. Now, let's move on to blood pressure cuffs. This is not one size fits all. It's one size fits most, but not all. Luckily for us, it has a built-in measuring guide right here. On professional cuffs, not home cuffs, professional cuffs, you will see a white stripe along a small edge of your blood pressure cuff. A white stripe. If you do not have a white stripe, you do not have a professional cuff. It'll still work, but it's not going to be as accurate. Okay? White stripe. Now, if I'm concerned, go ahead, just do it quick. Do it quick. There you go. Now, if I'm concerned that this may not fit my patient, Amy, can you take your jacket off and come over here, please? Are you choosing anything? Okay. If I look at her arms, I'm like, I'm not sure whether this cuff is going to fit her. I would take this white stripe and I'm going to go up underneath her arm about an inch above her elbow, about 2 inches above her elbow. I'm going to wrap it around the back side of her arm. Now, if it wraps more than halfway, it's too big for my patient. If I can't see either edge, it's too small for my patient. So this needs to wrap, thank you, between 1/3 and 1/2 the circumference of the arm. Now, if we use the wrong size cuff, it actually will affect our reading. If you use a cuff that's too small, it's going to make your patient's blood pressure look higher than it actually is. That's a problem. If we use a cuff that's too big, it's going to make your patient's blood pressure look lower than it actually is, which means we may not be treating the blood pressure appropriately. So we want to make sure we have the right cuff. Good? Okay. So what this is going to do, this is going to go around the patient's arm and be secured snugly over the arm. And it is going to have air pumped in it, and that air is going to expand the cuff. When it does that, it's going to press in on all of those tissues inside the arm. And the whole goal is to crimp off that artery. I want to crimp off that artery. When I crimp off the artery, the heart is still beating. Thump, 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 thump. Still pushing out blood. Still pushing out waves. So I got waves stacking up. But it can't get through because I crimped off the artery. So we're going to let the air out little by little, little by little, little by little. And as the air comes out, that artery starts to expand. And eventually that first wave is able to push its way through. And when that first wave pushes its way through, it's going to hit the top of the artery and make a thunk sound. That thunk sound actually has a name. It's called a Korotkoff sound. But it sounds like a thunk. So the first wave pushes through and it creates a thunk sound. What we want to do is look at our dial, our numbers, and see where our needle is when we hear that first thunk sound. Whatever number that needle is pointing to, that is the top number of our blood pressure. So we inflate the cuff, we deflate the cuff, and we're listening for the first thunk sound. Whatever number the needle is pointing to, that is our top number. Well, if the first wave was able to make it through, other waves can make it through. So they're going to move. So we're going to hear more thumps. Thump, 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 thump. We don't care about those. Thump, 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 thump. Don't care about those. Thump, thump. Don't care about those. What we're looking for is the last clear thump. The last clear thump. Whatever number the needle is pointing to, when we hear our last clear thump, that is the bottom number of your blood pressure. So we're going to inflate the cuff. We're going to deflate the cuff. We're listening for the first thump and the last clear thump. Okay? And we're going to use this to measure it. Now, I just told you that we're listening for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. Not a big sound. We got a microphone to help us, but it's still not a big sound. So you want as quiet of an environment as you can to pick it up. Okay, good. But if we're not over the artery, it's not going to help us a bit. Like I got a microphone on right now and it's here so people can hear me. But if I put the microphone over there, is it really going to be helpful? Probably not. Does that make sense? Okay, so we want to make sure we have our stethoscope over the artery that we're listening to. How many of you guys have ever had your blood pressure taken? Where do they put the stethoscope? Show me on your arm. Where do they put it? How many of you guys think that they put it right in the middle? Do they put it right in the middle? What do you guys think? Your artery is not right in the middle. So let's find our arteries. What we're looking for here is our brachial artery. Now, in order to find your brachial artery, you have to get your arm straight. So I want you to hold your arm out and get that elbow cupped all the way up. Don't let it sag. Elbow has to be straight. At the fold of your elbow where your lines are, take 2 fingers. Do we ever use our thumb? No. 2 fingers at the lines, but not in the middle. This is going to be on the pinky side. So where your pinky is, put 2 fingers there, put your thumb on the back and see if you can find your thumps. Anybody find thumps? Go more toward the inside. There you go. Put your thumb on the back. Put your thumb on the back. That holds better pressure. You feel it? Press a little harder. Got it? Got it? Got it? No? Okay. So, do you have a shirt on under your jacket? Okay. That's going to make it a little bit harder. So, we want to be on the inside. Right here. So put your thumb on the back. Your fingertips. Got it? Got it? Yours is right there. It's got a tendon right on top.
Try your other arm.
Try your other arm, but you got a tendon right there. We haven't find it. Find it. Find it. Find it. Find it. Okay. If you found yours, find somebody else's. Okay.
Find mine?
You can find it.
Let's find hers.
Try this
It's
arm.
really good in finding the pole.
I couldn't find it on that side.
Try it with other. I can feel it on there, but it's really hard to feel.
This was easy. The first time.
Yeah, I think yours is just very under a lot of tissue, so it's really hard to get to.
Oh, yeah, I was wondering how one goes here.
Thank you.
The shorter and the-
Okay. Did you guys notice that the artery, the thumps, is not in the middle of your elbow space? It's not in the middle.
That's good.
So if you just grab your stethoscope and plunk it right in the middle, you are not in the right space, which means you're not going to hear the thumps appropriately. Remember, this is a wave of blood hitting the top of an artery. We got to be in the right space. So finding that artery, especially when you're brand new, is super important. So it's an essential step. You've got to find that brachial artery. And then we want to make sure our stethoscope gets over that artery. So if I'm doing this on a patient, I'm just going to do it on me to show you real quick, right? But if I'm doing this on a patient And I know I've got to put my stethoscope over the artery. Well, when I find the artery, I don't have my stethoscope yet. I'm not there yet. So I find it. Yep, there it is. So I would have to put like an X marks the spot. Your patient probably doesn't want you writing on it. Okay, so that doesn't really work. So thankfully, our manufacturers that make these cuffs, they understand that. So right below our gauge is a little patch that probably says right arm, left arm with arrows, or you may have a line with a circle on it. That is your X. So you would don't do this on yourselves. You're going to do it on somebody else in a minute, but let me show you real quick. You would lay this on the patient's arm, but don't secure it. Just lay it there above the fold of the elbow. You want to see the lines above the fold of the elbow. You would find your thumps, and then you would line your arrow up with where you felt the thumps, and then secure the cuff securely. Now, that arrow tells you where to put your stethoscope. Okay, so you don't have to write on your patient. Good? Questions? Questions? Am I going too fast? Okay, so far, we have learned that our ear tips have to face the patient. The diaphragm has to be facing the dot if yours is adjustable. You have to find the artery, and you have to line up on the cuff with where you feel the artery so you know where to put your stethoscope. So that's what we've learned so far. Everybody with me? This is the most complex skill we learn. So now let's learn how to read this dial. As a CNA, we only go up to somewhere between 160 and 180. That is our stopping point because CNAs do normal. So 160 to 180, that's as far as we go. Do not go over 180. Over 180 hurts. Anybody know what effect pain has on blood pressure? It does. It makes your blood pressure higher. That's right. So if we go up to 240 and we hurt the patient and they have high blood pressure, well, do they really have high blood pressure, or is it because we hurt them? We don't know. They could maybe really have high blood pressure, but it could also maybe be because we hurt them. So now, do we have any usable information? No. So as CNAs, we only go up between 160 and 180. Do you guys remember what the normal values were? For the top number, 100 to 119, right? Well, we're going all the way up to 160 to 180. So if they got high blood pressure, we're going to know it, right? We don't need to go way up here. Got it? Anything over 120 is going to get reported to the nurse. Doesn't matter how high it is. High is high. Good? Makes sense? Okay. All right. So we only inflate up to somewhere between 160 and 180. And then we're going to deflate slowly and smoothly. Slowly and smoothly. We don't want that needle to stop. If that needle stops, it's bad news for us. We don't want the needle to stop. So we're going to inflate up to somewhere between 160 and 180. We're going to deflate so it slowly comes down. We don't want that needle to stop. And when it's deflating, it's going to be quiet. Quiet, 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 quiet. Now your brain is going to want to play tricks on you. Your brain is probably going to say things to you like, I'm not hearing anything. Are you doing this right? I don't know what I'm doing. What am I listening for? Did I miss it? Your brain's going to do all kinds of really weird things to you. You need to tell your brain, be quiet. All I'm doing here is listening. Okay? You inflate somewhere between 160 and 180, and you deflate and you listen and tell your brain to go take a nap. We're just going to listen. Where we hear the first thump, is our top number. We're going to hear more thumps, and we're listening for the last clear thump. That's your bottom number. And then it's going to be quiet again. So when we're taking blood pressure, we're going to inflate. It'll be quiet. You'll get some thumps, and it'll be quiet again. Everybody got that? Okay. So now we got to learn how to read this dial. You'll see that it's marked in 20s. So I got 20, 40, 60, 80, 100, and so on. The big lines in between are your 10s. If this is 20, that makes that 30, 40, 50, 60, 70, 80, 90, and so on. Your little teeny tiny marks are 2s. So if this is the line for 80, that makes this 82, 84, 86, 88, 90. Notice there's no 1s. There is no 87 on this dial. There's a space, but there is no 87. When you're reporting manual blood pressures, it's always best to report even numbers. If you report odd numbers, we know you're guessing. It's that simple. We know you're guessing. So we are going to inflate to somewhere between 160 and 180. We're going to deflate, and it's going to be quiet. What are we listening for? The first thump. So if you look at this, it's kind of hard to read for some of you out there, I know. But if you look at this, where is that first thump? Can you guys see that? Where is that first thump? This is the line for 100, 102, 104, 106. So the first thump we heard was at 106. And then we heard more thumps, thump, 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 thump. And then down here, we get our last thump. This is the number 60, so 62, 64. So what is this patient's blood pressure?
106 over 66.
There you go. That's a blood pressure, 106 over 66. Where we heard the first thump, where we heard the last thump. No addition, no counting, no complex math. All we're doing is listening. Where's the first? Where's the last? Good? Now, up until this point, all I've talked to you about is hearing, right? Where you hear the thumps. When you take a blood pressure and you inflate that cuff, as it comes down, that needle's going to tick as it comes down. Kind of looks like a clock. It ticks. That is not the blood pressure. A lot of people out there will tell you, just watch, and when it starts to tick, that's your blood pressure. That is not the blood pressure. Let me say that one more time. That is not the blood pressure. The top number is the first thump we hear. That is correct. Those ticks, those are just more waves joining the party, waiting to come in. It has nothing to do with your blood pressure. And people will report that. And we're medicating people that don't need to be medicated. Because people don't know how to take a real blood pressure. Good? Make sense? So blood pressure is always based on what we hear. Good? Okay. Let me tell you why you're going to have trouble with this. And you will. You will. You're going to have trouble with this. Half of you are going to have trouble with the top number. You're my dreamers. You can't help it. If you're the kind of person that goes out and picks daisies and there's nothing going on, right? Your brain wanders around. Yeah, you're going to have trouble with the top number because we inflate and we deflate and it's quiet. And it's quiet and it's quiet. And I'm hungry. I wonder what I should have for thump lunch. Thump. Maybe thump, taco thump. Bell thump. Oh, crap. Where did it start? Okay. So you dreamers are going to have trouble on the top. Because when it's quiet, your brain wanders. Now, some of you are going to have no problem on the top. It's simple. You inflate, it's quiet. First one shows up. I don't know why these other people have problems. This is easy. and you hear thumps. Now you are my dancers. You're going to have trouble with the last one because we are rhythm people, right? And our heart is a rhythm. It usually beats in a really nice, predictable rhythm. And your brain will actually get into that rhythm. How many of you guys filled in the next one? If you filled in the next one, you're going to have trouble on the bottom because you're not going to be sure. Was it a thump? Or did I fill one in? Okay. So I say this to let you, so that you understand you will have trouble either on the top or on the bottom, or like me, on both. It took me a long time to learn blood pressure because nobody explained it like this. They just said wrap the cuff around, inflate, deflate, and hope for the best. So it took me a long time to get it. And if somebody had told me, hey, you might have trouble on the top because your brain wanders, I would have known to pay a little bit closer attention. So I tell you these things to help you develop strategies to overcome these two particular situations. Good? Questions? You'll see what I mean in a minute. All right. Turn in your books. Page 50. Hold on. 57. I'll have it on here. Okay. Okay, on page 57, the gray box on the right-hand side has 15 questions. I want you to look at number 8. Now, I know it's black and white. I know it's kind of hard to read, but do the best you can. If you look at number 8, there is a blood pressure gauge there. It shows you where the first thump was heard and the last thump. See if you can identify the blood pressure. What do you guys think it is? Where is the line for the first thump? 130. Okay. Where is the line for the last thump? So what is this patient's blood pressure?
130/90.
Is that normal?
No.
What would we do with that? Report it to the nurse. Let's look at number 10. This one's a little harder, but do the best you can. Where is the first thump?
108.
104.
106, 108, somewhere in that vicinity is probably pretty accurate. Where is the last thump?
62.
62. So 108/62. Is that normal? I would kill for that blood pressure.
Yeah, I would
test. I haven't seen that in years. All right. So you guys understand how to get a blood pressure? Do you understand that when we take a blood pressure, we inflate, we deflate, and it's going to be quiet? We're going to hear our first thump. That's our top number. More thumps we don't care about. Last thump is our bottom number. Quiet again. Make sure that you deflate all the way to 0 because you're going to get excited in just a few minutes. You're going to get very excited when you hear your first one. And you're going to be like, I heard it. And the needle is still hanging out somewhere up here. And that arm is going to reach out and slap you eventually because it wants blood flow. So even though we're excited, we're going to make sure that needle goes all the way to 0 before we take the stethoscope off our patient. Got it? Okay, now I'm talking to you about this needle, right? It goes up, it goes down, it has to go to 0. I'm talking all about this needle. What we haven't discussed is the fact that you control this needle 100%. If that needle stops, that's you. You did that. If that needle goes too fast, that's you. You did that. if that needle doesn't go to 0, that's you. You did that. So we have to learn how to control that needle. And that's what we're going to do right now. So I'm going to pass out as many cans as I have. Let's see what we can do here. Okay, does anybody have one of those cups with a metal bar in it? A cup with a metal bar?
Like this, you mean?
Yes, okay. So, yes. So let me have your can back.
Oh, we get.
Okay, that's fine. So you use that one, and you need a can. Okay. All right. I don't know, guys. We may have to share. I don't think I need one.
Miss Patty,
Okay.
can I use my water bottle?
Yes.
Or can I use-
That one is too small in the bottom, but that can will work. Yes. Perfect. Okay. All right. So you're good?
Yeah.
Okay. All right, so I'll give this to you then. Okay, so what I want you to do is wrap your cuff around your can. And you want to wrap it around your can so that when you wrap it around the can, the gauge is facing you. So when you wrap it around the can, the gauge needs to face you and the tubes need to hang down. Not like this, like this. And you want it snug. Wrap it snugly around your can. Okay, so yours, let me help you with yours. This is a home cup, so it's a little bit different. So we're going to okay, hold on 1 second and I'm going to help you. So this is always going to stay hooked like that, okay? Squeeze that around. Let me borrow that. Oops. All right, so thank you. So we have a can with a cuff wrapped around it. Now I'm going to turn around so you guys are all seeing things from the same vantage point that I am, okay? So I'm going to turn around here. All right, so let me back up just a little bit. So everybody see me? Everybody see me? All right, so what I'm going to do with the, okay. So what I'm going to do with this is I'm holding the ball in the palm of my hand with the tubing facing up and the little silver dial between my thumb and index finger, just like this. Don't hold it like this. You want to hold it so the ball is in your hand and you can reach this little silver button with your thumb and index finger. Righty-tighty, lefty-loosey. So we're going to turn this little silver dial to the right just until it stops. Don't tighten it, just until it stops. And then, once it stops, there we go. Then I'm going to squeeze this ball until this needle goes up somewhere between 160 and 180. So I'm going to squeeze it. And then I'm going to hold this ball between my thumb and index finger and not let go. I'm going to turn it ever so slightly to the left until that needle starts to come down. Do you guys see the needle? See how the needle is coming down? Now that needle is going to slow down, so I have to keep opening and keep opening and keep opening and keep opening and keep opening to keep that same rate. So let me show you on the screen one last time. Let's see here. So I'm closing my valve. Need a light over here. I'm gonna inflate. I'm gonna hold that valve between my thumb and index finger and slowly turn it to the left so that the needle comes down. And I want a nice, slow, controlled rate all the way to 0. If your needle does this, that's you. If the needle stops, you got to open it a little more. So go ahead and give it a couple good tries. Give it a couple good tries. Get it? No? Okay. You will. Yeah, turn this until it stops. So go ahead and pump. Now with your index finger and thumb, open it out just a little bit to the left. Okay. Little bit. There you go. Now see how it's slowing down? We gotta open a little more. And when it slows down, you gotta open a little bit more. When you get to 0, do it again. Open it up. To the right. Okay, when you think you've got, if you need help, please raise your hand. When you think you've got it, take your cuff off your can. That way I know who's still working. When you think you've got it, take your cuff off your can.
Mine worked the first time, but then when I do it, like the air comes out.
Turn the back up, turn it up.
Like the air was coming out so fast.
Yeah,
I
and then you
just
can pump it up.
And then, ever so slightly. Good, very good. Very good. So, yeah, this has to go all the way this way to pump it up, and then we turn it this way to let it get to the right. All right. Any questions? Any questions? All right. You're going to break up into groups of 2. You're going to take her blood pressure. She's going to take yours. You're going to take her blood pressure. She's going to take yours. Okay, groups of 2. I don't care how you do it. And then once you're done taking hers and she's done taking yours, you're going to switch groups. I want you to take 3 blood pressures on 3 different people in the next 17 minutes. Go. Oh, real quick. Hold on 1 second. I forgot to tell you guys something. When you're taking a blood pressure, you need to make sure the arm is supported. So it needs to be laying on the table. So move the chairs as needed to make sure that it's laying on the table. When you put the stethoscope there, remember I told you that when you lay the blood pressure cuff, you need to be able to see the lines? Because we need a place to put our stethoscope. If you shove that stethoscope underneath the cuff, it muffles or flattens the sound. You're not going to hear it well. And the blood pressure will actually not be accurate. So when you put the cuff on, make sure that it's above the fold of the elbow so you've got a nice clear place to put your stethoscope. Make sure the arm is supported, both feet flat on the floor, not crossed at the knees. It's actually easier to take a blood pressure if you are standing. If you try to sit and take the blood pressure, it's very awkward. and you're not over the gauge, so it'll affect what you actually see. So feel free to move the chairs around to get in the right position. Left arm is best, but we're going to ask which arm do you prefer. If they say either, go with the left. If they say right, don't argue.
Oh,
I just need to print off there.
Yeah.
Wait.
Look his name. Where you supposed to say?
I think
well, you can leave it. It's easy to leave it on.
yeah, but the thing is, her artery is here, right?
What we do?
It's like when random as you go up.
Okay.
I guess.
I heard this.
You really should. You should learn how to do this.
Oh, I know. Did you hear it? Did you hear it better?
All right, give me a second.
You have something at home you can practice on?
Yeah.
Okay.
It's okay. It's okay. Whatever. At least for her. That's her fault.
So little.
I need a break.
There it is.
It's already Let's try this out.
Remember, you're not gonna do anything at first. It's gonna be quiet. We want to inflate and then listen.
Right.
Try some feel.
That's good for me.
Right.
I will take that.
You're not gonna hear it.
Okay.
You're not gonna hear it.
Right.
Okay. Okay, all right. So who's your patient?
We're doing on her.
Okay. So.
Oh.
Oh.
So.
You gonna do it one more time?
Zero.
Okay, all right. I'm gonna
I found people holes and I put this here right there. Showing where her artery is.
Let's move that up just a little bit because we want a nice clear place.
The hard part is like even like the slightest use of right.
I think what you were doing was you thought this listened.
I think that's
stethoscope around where you
gotta
want
like
to
master like the speed of it
You're not gonna hear anything.
and then holding.
I know, but
Holding this without moving.
I did.
Okay, I definitely heard it. Didn't sound, but I heard it was going.
While I was holding it.
Now you're gonna hold that here. Hold it firmly. You're gonna inflate. Keep going.
Yeah, I was trying.
A little bit more. Okay, now open it ever so slightly, just a tiny, tiny bit. So that the needle, a little bit more.
Your last thump was at like 80 something.
Now listen. Keep opening.
I have high, you can do mine.
I might be a little hamster. I was getting into that rhythm.
Do you want to do hers while he tries mine?
Open it all the way. We need to be at zero. No, 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 no.
But I missed the bottom.
Okay, all the way to zero. All the way to zero. Do not reinflate in the middle. When you reinflate in the middle, it causes vascular spasm and your blood pressure's not gonna be accurate. You never reinflate in the middle. You go all the way to zero, and then if you need to redo it, you can. But all the way to zero.
So now you can do it again.
Okay, one more time, and then we're gonna let her arm rest, because this hurts.
Oh, really?
Yes.
Let's do it.
Can I try somebody? I haven't.
Yeah, she hasn't tried anybody yet.
Yeah.
So, can we borrow you?
Here, you wanna do mine? You got hers, okay, now you're switching around.
Okay, so let's, can we come on and do yours? Okay, so hold this. We're gonna go around.
I have to go.
Oh, okay.
I'll see you Wednesday.
Thank you. See you Wednesday. Can we use your right arm? It would be more convenient. So go ahead and lay your arm out on the table.
This one was easier.
Don't use your thumb.
This one's right here.
And you want her arm to be straight. So can you pop your elbow up?
Yeah, like
I want to kind of
don't press a little bit, right?
And you're gonna put your stethoscope in place.
Right in comment.
Okay, I definitely heard it, but my finger was like tapping on this.
Okay, it's not closed all the way. You need to close it. No, it's not closed all the way.
I did now. I just did.
Open it a little bit. Little bit. Little bit. You heard? Yeah. Okay, that's all I'm looking for right now. Guys, I'm not worried about you getting the blood pressure. I'm worried about you hearing thumps. That's all I want you to concentrate on is hearing thumps. Be able to hear thumps? Be able to hear thumps? Okay, change partners. Grab somebody from over here. I want you to take at least 3 blood pressures on 3 different people. Okay, hold on. Hold on. Let me help yours. We're going to get all of the air out first because it's got air in it and it's not going to let us put it out. So we're going to open this up. All right, get all the air out. Okay, so now we're going to place this over the arm. We're going to find the artery. There it is. And I'm going to secure that cuff. I don't mean to be pushing on that. There we go. Okay. So you're going to put your stethoscope there. Squish. Are you right-handed or left-handed?
Okay.
We love that. So my blood pressure is great.
Yes, mine was a little high, but not bad.
Don't tighten it. Don't tighten it. Because then when you go to loosen it, it goes, woo!
Probably had it, right?
Okay.
Yeah, they normally have these small ones.
Let me work this for a second. Because for some reason, yours is. Okay. So we just want to close it, but not tighten it. But we want it close. So we're inflate it. And then we're going to slowly
Sometimes.
And they just throw at the. Yeah.
So like the movement.
Yeah. Wow.
Did you hear her?
Oh, I know her. I know her.
Clearly it's been good. Like 115 over something.
I want to see what he gets to compare.
Do you hear him? Good.
Yeah.
Good.
I got it. It's under.
Tighten it.
Fine.
Okay, for those of you playing along at home, students are just practicing blood pressure. You should be practicing as well. Happy badges. Did you hear thumps?
Yeah.
Did you hear thumps? Hear thumps?
It was low.
Mhm.
The last one was low.
Yep.
I take care of that last.
Did you guys hear thumps?
Yeah.
Everybody hear thumps? Okay, go ahead and finish up the one that you're on.
Yeah, I was like, again, something else.
All right, was everybody able to hear at least one good set of thumps so I can set you loose on the public at home?
Yeah.
All right, here's the deal. You're not accurate. You're not even close to accurate. It takes about 45 blood pressures before you even really start to become accurate. So when you're at home practicing on friends, family, neighbors, basically anyone you can tackle, if you get an abnormal reading, please do not call 911. You are not accurate. Have your patient go to a automated cuff in Walgreens, Walmart, any of those places, and have the machine verify it. Don't ask the people in the ambulance to come to your house and verify it. And then they can follow up with their doctor if there seems to be a problem. Sounds fair? Remember, you are not accurate. But if it takes us 45 blood pressures to get to where we're starting to put all this together, that means you got a long way to go. You have a lot of practice that needs to be done. So you really should be practicing on anybody and everybody that you can, but nobody under 13. This hurts little arms. We don't want to make pediatric patients afraid of medicine. Don't practice on anybody over 80. They got their own health issues. Leave them alone. But if they're between 30 and 80, they're fair game. If you can tackle them, take their blood pressure. Especially with tomorrow being Halloween. Set up a candy station and take blood pressures. Okay, so make sure that you're practicing this. You can bring your blood pressure cuffs to class from now on, but we're not coming back to blood pressure. You will have some time built in for practice starting next week. You can practice blood pressure. Remember, it is not tested on the state exam, and we're not going to set aside any additional time to practice. So this is one you really need to be practicing at home. Sound good? Did I go too fast for anybody today? Is anyone lost? No? Okay. Review sheets are here. Grab a review sheet. Please remember, next Friday, not this Friday, next Friday is CPR, and it'll be your last opportunity to get it for $45. After next Friday's class, your price goes up to $55.
Do we prepay for that or?
No, just pay on the day. Yeah, pay on the day. All right, have a fantastic Halloween.
Miss Patty, I'll be here for your next CPR class.
Oh, good. Okay, very good. Very good.
No homework?
Oh, yes, I'm sorry. Thank you. Chapter 4, homework, chapter 4, and it's complex. What I need you to understand out of chapter 4 is just the normal signs of aging for each body system. Don't get all caught up in the body systems. Nobody cares. They're not going to quiz you. It's the normal signs of aging that you need to concentrate on. We'll do a brief review in class on Wednesday as well.
Have a good day.
Have a great day.
So